Dear guests and valued speakers, we welcome you all to the Neurotechnologies from a Multidisciplinary Perspective Conference. Organized jointly by Kadir University and Başkent University, together with the support of Lexpera. We now kindly invite Professor Ozan Erözden, the Dean of Kadir University Faculty of Law, to the stage to give his opening speech.
Thank you very much for coming to this event, and also for those who are going to give insightful speeches here. Many thanks for their contributions. Neurotechnologies from a multidisciplinary perspective is a conference which tries to elaborate the different aspects of neurotechnologies which are having a part in our lives, not only specifically for medical purposes or other, but for daily usage as well. So we think that the importance of neurotechnologies and the place of neurotechnologies are going to get even bigger in the future. I'm not going to make a long speech, so I would like to thank to the members of the organization committee, first of all, Professor Aslı Demirtaş Tatlıdede, my colleague and friend from Bakış University, who was very active in organizing this conference together with me. I would like to thank our rector, Professor Sondan Durkanoğlu Feyiz, for giving all the possibilities for making this conference happen. And Ece Uyanık and Dr. Doğukan Bilgöl were very active also in the organization of this event. Before ending my words, I would like to mention a dear friend whom we lost very recently, neurologist Dr. Zerrin Yıldırım, who has been a very active person, both professionally and also socially. She was her presence was a source of joy and also professional enthusiasm. So I'm very deeply sorry for having lost her. She has been present in the previous conferences, making neurology, law, neuroscience, putting all these subjects together. So thank you very much for coming again, and then I hope this conference will be a successful event in this subject. Thank you very much.
We also kindly invite Professor Sondan Durkanoğlu Feyiz, President of Kadir University, to stage to give her opening remarks.
Good morning, dear distinguished speakers and dear guests. Welcome to Kadir University. And some of you might know that I'm a physicist, but I still have a little thing about the issue. You know, as a physicist or as a person on the street, I never feel that we have a free will. We are being coded at the time we are born. The first coders are our family. Second coders are our first schools, and secondary schools, and the schools we go, and then our friends. And as a human being, we think that we are an exceptional creature on the planet. We're not. So And I don't know if it is up to me or not. The law has to be rewritten. And neuroscientists and lawyers, they should come together and they should redefine the crime and the punishments. Because we know that no one on this planet has free will, and the law is based on the free will of humankind. And we have to rewrite it, and I'm very happy that Ozan Hocam, with the leadership of Ozan Hocam, we are organizing conferences just like that, bringing the people from different disciplines to discuss on these very important issues and come up with, hopefully, the new regulations and the rules which will humanize us more, and hopefully we will have more peaceful way of living. So I thank you, Ozan Hocam and his teams and the organizers for organizing this very important conferences, and we will make sure that this conference will have the series ongoing, and at the end, the ones who are here will be the leaders of maybe shaping the new law or constitutions. I don't know, it's all up to you guys. And again, thank you for coming and being part of this important conference. And when I have time, I will be one of the participants in the conference. And have fruitful discussion. I am sure at the end, we will all, be benefiting from the conferences. Thank you and welcome.
We are grateful to Professor Erezden and Professor Durkanoğlu Feyiz for their opening remarks. Now, to begin the first session of the conference, we kindly invite Johan Komprodon to stage for his keynote lecture. We also kindly invite Aslı Demirtaş Tatlıdede to stage as the moderator of this session.
Hello, everyone. Thank you very much for being here. I also find it very valuable to have both neuroscientists, neurologists, as I am, psychologists, and law all together. It's really an organization that needs quite an effort to put different areas together. So I hope you will enjoy it. It's my pleasure now to announce my dear friend, Professor Johan Komprodon Jimenez. Johan is the Chief of Division of Neuropsychiatry at Mass General Hospital and Associate Professor of Psychiatry at Harvard Medical School. He is the founding director of MGH TMS Clinical Service, a member of Psychiatric Neurosurgery Committee, and attending physician in the departments of psychiatry and neurology. He directs the Laboratory for Neuropsychiatry and Neuromodulation. His research uses multimodal combinations of brain stimulation, neuroimaging, neurophysiology, and behavioral methods to investigate neural circuitry and plasticity in a transitional manner. And his laboratory works with a wide range of invasive and non-invasive neuromodulation techniques, including transcranial direct current stimulation, transcranial magnetic stimulation, electroconvulsive therapy, deep brain stimulation. Today, he will be talking about neurotechnology and precision brain medicine, moving the focus from populations to individuals. Johan?
Well, it's a pleasure to be here. Thank you so much for the invitation. I will start saying that a while back, a few years ago, I studied both philosophy and medicine with the idea of trying to understand and think about problems at the interface of the neurosciences, the practice of medicine, bioethics, epistemology, and the legal implications. So it's a pleasure to see that you share this interest and to collect a group of people coming from such different disciplines to think about it. So I look forward to the program and to the rest of the lectures all day today and tomorrow. And I will get us started by introducing some context about neurotechnology. I'll talk about some specific modalities of neurotechnology, mostly those that are treatment-oriented, different types of device-based neuromodulation, technologies. And I'll highlight some of the questions that I think make this space particularly salient and relevant from a bioethical and from a legal perspective. And that is the fact that we're starting to move in medicine broadly, but also in the neurosciences, from population-based solutions to patient-specific solutions. This is hard in the brain, it's hard in neurosciences because the brain is complex, it's very heterogeneous, it's different from subject to subject, but we're getting there. And this, while it offers lots of interesting solutions for the treatment of patients, it also raises lots of new and challenging problems that hopefully we can start discussing. All right, so we'll do this more interactively. So I'd like to start by setting up the framework. And there's both a biological framework, a clinical framework, and a technological framework that we need to clarify before we discuss neurotechnologies, neuromodulation. The biological framework is this one. You know, the brain is complex, and there's many different levels of biological analysis, and they're all relevant. There isn't one that is more relevant than the others. So you have genes from the more microscopic to the more macroscopic in this inverted pyramid. Genes that encode for molecules, molecules that make up cells, cells that connect in synapses. These microcircuits define what we call brain regions, language regions, visual regions. Then they connect in circuits, networks. These are circuits just like the ones in your cell phone or your computer, but instead of making made of silicon, they're made out of proteins, fat, and sugars. And then we have the organ dynamics, right? So there's blood flow, and there's immune cells and immune molecules. And eventually you have the brain functions, behavior, cognition, emotion, movement, perception. And when these functions break down, we call them signs or symptoms. Right? And this is what clinicians treat when they're sitting face-to-face with a patient. So these are the clinical syndromes in neurology and psychiatry and neurosurgery. But beyond single patient problems, we also have population dynamics. This is what epidemiologists studies. And above that, you have cultural, religious, moral questions that I would argue are also relevant for to understand the brain, both in health and disease. There isn't a single level of analysis that is more relevant than the others. But I would argue, next slide, please, that the circuit level is particularly relevant. Next slide, please. Because it is precisely the circuit level where cognition, emotion, and behavior are actually encoded. So this is not to say that cells are not important for cognition, emotion, and behavior, but they're important to the extent that they shape the circuit dynamics where these computations are happening. So this is a more pathophysiological, mechanistic, neurobiological reason why circuits are important. But there's also a more pragmatical, clinical reason that has to do with treatments. We have three main types of treatments in neurology and psychiatry. We have, next slide, please. We have medications which intervene in the brain at the level of molecules. Then we have, next slide, please, what we call non-somatic therapies. These are behavioral therapies, psychotherapies, rehabilitation, physical therapy. Again, they are not biological treatments, but they are treatments nonetheless. In the previous slide, by intervening the brain at the functional level. And then last but not least, we have devices. This is a third branch of therapeutics. And devices or brain stimulation, these are the neurotechnologies used for treatment, intervene in the brain precisely at the circuit level. Right? They talk to the brain in its own electrical language. And this is why both from a physiopathological or pathophysiological and a therapeutic reason, the circuit level is particularly relevant. So we'll be focusing our kind of biological approach to the brain at the level of circuits. Next slide, please. Now, how do we go from circuits to patients? How do we go from circuits to symptoms? It's not always straightforward, particularly in the more psychiatric types of problems. So here on the left side, you have our current definition of what depression is. And I'm just choosing depression because it's a condition that has indications for many neuromodulation devices. So depression is defined strictly phenomenological, strictly clinically, without any biological input into the definition. You have to meet criteria by having 4 or 5 of these symptoms together over a period of 2 weeks. And you should not be able to explain that because of substance use or other medical reasons. Now, next slide, please. There are 227 ways to combine the symptoms and meet criteria to have major depressive disorder. This is a lot of ways. And you can have two patients who meet criteria, and they don't share a single one of the symptoms. So clearly, this is a very heterogeneous condition. And we've been challenged by trying to, next slide, please, understand it from a neurobiological perspective. Next slide, please. When we try to say what are the neural correlates of depression as a whole, we have failed systematically for many years. And I would argue the reason is because that was the wrong question to ask. See, we've been thinking about depression as a disease, but if you go deeper, you see that depression is a clinical syndrome. Clinical syndromes in medicine are constellations of phenomenological presentations, so either signs that physicians objectively or psychologists objectively identify, and symptoms that are subjective complaint of patients. So in psychiatry, in neurology, in cardiology, this is defined as a clinical syndrome. It's always phenomenological without any input from biology, and it's always heterogeneous. And it's always the case that you have many different diseases that coalesce into a clinical syndrome. For example, we call left heart failure when you have certain types of problems that compromise the left side of your brain. Now, you could have hypertension leading to left heart failure. You could have a valvular disease. You could have an arrhythmia. You could have a problem with the heart muscle. You could have a problem with the pericardium, which is the skin that surrounds the heart muscles. All of those very different diseases may give you left heart failure. But they're very different diseases. They require very different treatments. So we're at the same stage with most psychiatric conditions. These are syndromes. And because they're syndromes, there are many different diseases behind them. So if we try to ask what is the specific biology for all of depression, you cannot answer the question because it's not an answerable question. Now, there is an approach to dissect the syndrome into its core units of behavior, cognition, emotion, autonomic function, and then we have a much better chance of identifying these biological substrates for the core components of depression. So when we talk about depression, we say it's a mood disorder, so it's obviously you're going to have problems with mood. Now, mood or emotions come in two types of flavors, if you want. You have negative emotions and positive emotions. And we used to think that these were the two ends of a continuum. The negative emotions on one extreme, positive emotions on the other. We've learned over the years that that's not true, that there's two distinct continuums, one for negative emotions, one for positive emotions, with distinct anatomy, with distinct physiology, and with distinct treatment requirements. And in depression, you may have one, the other, or both. You may have either excess of negative emotions or deficits of positive emotions. And next slide, please. So if you have the negative emotions, I'm pointing here, you see through this slide, I'll be pointing to specific hubs or circuit or nodes, and I'll be talking about circuits for the rest of the talk, but this is for visualization purposes that are critical hubs in this circuit. So this is subgenual cingulate. Actually, you go one back. Good. So this is subgenual cingulate, which is a key region that is hyperactive in depression. It can be hyperactive in healthy individuals if you induce sadness, and it's a target for deep brain stimulation for depression. But then again, you have the deficits in positive emotion. Next slide. I'm pointing here, the arrow is a bit slight, but to the VTA, the ventral tegmental area, the anterior part of the midbrain, which is the origin of the reward circuitry, or the pleasure circuitry, that process positive emotions, also motivation, also the capacity to learn based on good things that happen to us. Now, emotions are important for depression, but depression is more than just sadness, it's more just the lack of positive emotions. They're also cognitive, behavioral, and autonomic functions. So next slide. You have problems with lack of energy, with this. Oh,
so this one is working.
Oh, good. This is so much better. Thank you. So you have problems with energy. You have these nuclei here in what we call the brainstem that are ascending to the brain and regulating energy and alertness. You have sleep and appetite, the more autonomic functions. They're focused here in the hypothalamic nuclei. Cognition and attention, mostly executive function, a capacity to plan, to multitask, to define priorities. I'm pointing here to, on the other side will be the dorsolateral prefrontal cortex and the circuitry that is cortical-cortical and cortical-subcortical. You have rumination and guilt, negative self-perception, pointing here to what we call the posterior cingulate cortex. This is a key node of the default mode network. It's a network that is in charge of processing information about the self. And sometimes that is adaptively, sometimes it's maladaptive. And last but not least, we have self-harm or suicide, which is a very complex function. I would argue it's a clinical syndrome of its own. That's a topic for a different talk. But regardless, there's a lot of evidence that this node here, the anterior cingulate, both the rostral and the dorsal, carry a signal at many different levels of biology, again, that is very relevant to explain the severity of the suicidal patient. So if you look at this map, one of the critical answers or, I think, insights is no wonder we have been challenged with defining the circuit for depression, because there isn't a circuit for depression. It's all over, right? The other insight is that, while many of these functions are present in depression, they're not just present in depression, right? You have executive deficits, for example, in most, if not all, of psychiatric conditions. You have it in Parkinson's disease, in traumatic brain injury, in frontotemporal dementias. You have problems with self-harm in traumatic brain injury, in schizophrenia, in borderline personality disorders, in certain stages of Alzheimer's disease. So again, this dimensional approach allows us to think beyond the clinical syndromes in what we call in a transdiagnostic fashion. And the idea is that if you find solutions to some of these dimensions, treatment-oriented solutions, you may not only have a solution for these dimensions in the context of depression, but it could be a solution broader at the transdiagnostic level. So this is the dimensional clinical approach. This is the neuropsychiatric approach to patient care. Again, if you want to formulate a patient at the circuit level, it's difficult to go from the syndrome to the circuit. But if you go from the syndrome to the dimensions, then you have a much better chance of formulating the patient at the level of circuits. And this is important because we now have all of these technologies which are allowing us to sometimes very precisely engage circuits. So I need to have a sense of what's wrong with the circuits of a given patient if I want to offer a circuit-oriented solution. So as we talk about brain stimulation technologies, we have to set the stage. It's important to know that there's a whole group of technologies. And again, I'm going to highlight the term technology. These are not treatments. These are technologies. And some of the uses of these technologies become treatments. And some of these technologies become different types of treatments, depending on the use, the protocol, the specific parameters. And we'll talk more about this in a second. But again, the way we tend to classify them is based on their safety and tolerability profiles. So we have the invasive or surgical techniques. These are things like deep brain stimulation, which we're seeing here, where we insert an electrode in deep parts of the brain. We have vagal nerve stimulation, where we place a coil in the left vagus nerve, which is a nerve that goes in this side of the neck, and it goes from the brain to all organ systems, but also from organ systems back to the brain. Now, beyond the surgical ones, which obviously are indicated for the more severe and more refractory patients, in medicine in general, you try to go from less invasive to more invasive with a few exceptions. Then we have the convulsive therapies. These are non-surgical, but still require general anesthesia. We are inducing a seizure in the brain of a patient under general anesthesia in an OR-like environment, under pharmacological paralysis. The body is not shaking, but there's a seizure in the brain, which is therapeutic, induces changes that we're starting to understand better today that are treating mostly depression, bipolar disorder, and both depression and mania, schizophrenia, and catatonia. These are the main indications. There are also status epilepticus. There's certain behavioral issues in Parkinson's disease that are treated with ECT. And there are other more experimental options like magnetic seizure therapy, which is TMS on steroids, if you want. It's trying to induce a seizure with TMS, something we try to prevent when we do TMS proper. So we have the invasive or surgical, we have the convulsive, and then we have the non-invasive. These are the softer techniques, the ones that are indicated for a larger audience, or a larger number of patients. They tend to be ambulatory treatments, meaning patients can walk themselves, drive themselves, use public transportation, whatever they want, to the clinic, receive treatment, and then go back. Sometimes, in some novel technologies, are becoming home-based devices that we can use as well for non-invasive techniques. And we'll discuss a couple of these indications, both TMS and transcranial alternating current stimulation. So, while there are many different technologies, they have several things in common. These are the indications from a regulatory standpoint vis-a-vis the FDA in the US. So the surgical techniques, deep brain stimulation, were first indicated for chronic pain, although eventually the FDA revoked that indication. So today it's not an FDA-approved or clear indication. DBS is mostly used for movement disorders, so Parkinson's disease, essential tremor, dystonia. It's also approved for obsessive-compulsive disorder in psychiatry, and the latest approval was for epilepsy. You start seeing a pattern here, and that is that these are treatments for both neurological conditions and psychiatric conditions. These are going to be difficult terms to define as we go deeper into circuits, and the reason is because once you start thinking about the brain from a circuit perspective, these distinctions between what's neurological and what's psychiatry become less relevant, become very difficult to define. And one very pragmatic example is that these circuit therapeutics, these circuit-based treatments, have indications in what used to be psychiatry or neurology, or still psychiatry and neurology. So vagal nerve stimulation, it's approved for epilepsy, for depression, and more recently for the rehabilitation of the arm after a stroke. Then we have things like transcranial magnetic stimulation, is approved for depression, the acute management of migraines, also prophylaxis of migraines, obsessive-compulsive disorder and addictions, particularly smoking cessation. And transcranial current stimulation is still not approved in the US, although it's about to get approved for depression. There's some trials for focal epilepsy in children, but it is approved in Europe for a number of indications. So a whole set of indications across the border of psychiatry and neurology. And again, while all of these techniques are different, they have different indications, they have different engineering, they have different mechanisms of action, there is indeed a shared paradigm or framework that is technological, biological, and clinical. And this is exemplified by these figures. You know, whenever you use any of these techniques with a patient, there's always three things you need to know. You need to know what is the circuit that you want to change. That's going to be defined by the condition you're treating or by the symptoms a specific patient has. Then you need to know what's the target that will give you access to the circuit. So circuits have many different nodes, but by definition, you don't need to actually engage all these nodes directly, because by definition, these nodes are connected. So if I change one of these nodes, I will not only change this node, but also the impact that this node is having on the distal nodes, as long as they're connected. And again, the goal with all of these device-based therapies is not to change these or these, is to change the dynamic across these nodes. So you're going to choose a target, which is a window that gives you access to engage the circuit. So again, these are the two more anatomical or structural variables. You have to know the circuit, you have to know the target, gives you access to the circuit, and last, you need to know the direction of modulation. Eventually, what we want to do with all the techniques is change physiology, change function, change these computations. And physiology is happening constrained in the anatomy of a given circuit, but it's still this physiological dynamics. What do you want to do when you apply this treatment? You want to increase or decrease excitability? You want to increase or decrease the connection between these nodes? You want to increase specific frequencies in the, what we call the gamma range or the alpha range? It depends on how you formulate the disease, how you formulate the response biomarkers. But you have to have this idea of a response biomarker in order to implement these techniques. So you have to know the circuit, you have to know the target, and you have to know the direction of modulation. So this is the framework as a summary to get us launched. The biological framework is that of circuit neuroscience. The clinical framework is that of thinking of syndromes versus dimensions and being able to formulate patients dimensionally so that we can get to a circuit-based formulation. And last is the technological framework with invasive, convulsive, and non-invasive techniques. And the question is, can neuromodulation bring precision medicine to the clinical neurosciences? Precision medicine being these patient-centered, individualized approaches to treat patients, not just diseases. And again, if we're going to use these techniques, we have to know the circuit, know the target, and know the direction of modulation, but not for depression or OCD or Parkinson's or stroke, but for the one patient who's sitting in front of us. So the premise for treatment development with neuromodulation is that all brain functions and all brain diseases are coded at the level of circuits. So that means you have to know the anatomy, the physiology, and the behavioral computations. These are the three variables that you need to understand. And if we can formulate a condition at the level of circuits, then it's a potential indication for neuromodulation. So this is the treatment development paradigm. First, we have to know pathophysiology, which is the mechanisms of disease. And again, understand the circuits, anatomy, physiology, and behavior. Then we have to identify biomarkers. Understanding pathophysiology is not enough to develop treatments. We have to define biological signatures that are clinically relevant. And there's different types of biomarkers. You have disease biomarkers, severity biomarkers, prognostic biomarkers. But the response biomarkers are the ones that are particularly relevant for treatment development. These are dynamic biological signatures that change over time. And when they change, you don't only have a biological change, but you have a clinical change that goes with it. And once we've identified the response biomarkers, we can do what we call biomarker-driven treatment development, or bottom-up treatment development, which is in the framework of what we call experimental medicine. Again, trying to have first an understanding of pathophysiology, to then define these biomarkers that will help us more rationally develop treatments. And we can do this at the group level, but this is a necessary framework to start thinking about precision medicine or individualized treatment development with neuromodulations. So the idea with precision neuropsychiatry or precision brain medicine is, as I've been highlighting, this idea of individualized treatment development. And it's that we treat patients, not disorders. So there isn't just a protocol for depression. There's a protocol for Mr. X, who happens to have depression. And it will be different from a protocol for Mrs. B, who also has depression, but may have a different type of depression. And we try to move away from this one-size-fits-all into more patient-specific therapies. But it's not just about having individualized protocols. We also want to have individualized treatment selection algorithms. So we're lucky that we have a series of treatments in psychiatry and neurology that work, but we don't always know who should get what when. And what we need is algorithms that can provide evidence to these choices so that clinicians can decide, again, for Mr. X or for Mrs. B, whether they should get treatment A or should get treatment B. While both treatment A and B may are reasonable treatments. They may all, for example, be treatments for depression, for anxiety, for Parkinson's disease, but which one should this one person get? And again, since the framework is the behavior, anatomy, physiology framework, if we think about individualization, we want to control these three factors. We want to control anatomy, which is controlling the where. Where do we place the coil? Where do we place the electrodes? So some examples are MRI-guided TMS, and I'll discuss it in a second. We may also want to control physiology. So that's not the where, but the when. They have very temporally varying dynamics in these oscillations and these computations. Understanding how they happen for any individual patient will help us understand how to integrate our stimulation protocols with what's going on in the patient's brain. And last but not least, we want to control the what. And this is the actual mental state, the behaviors. Individualizing based on the specific symptoms, the specific thoughts for OCD, specific symptoms for depression, the specific features of a tremor or rigidity or gait issues or sleep issues in a patient with Parkinson's, it's going to be important. And if we can individualize based on anatomy, physiology, or behavior with devices, then we're moving into this precision neuromodulation space. Let me skip this part. So I'll give you now some examples beyond just general frameworks on how this is happening as of today. I will start by talking about how we control the anatomy, then we'll talk about how we control physiology, and last, how we control the state. So let me give you some examples with TMS. TMS, transcranial magnetic stimulation, it's I think we may still have a physicist in the room, is a biophysical application or medical application of Faraday's electromagnetic induction principle, which basically says that if you have an electrical circuit that is circular, meaning we have electrical current going in a circle, it will induce a magnetic field. And this magnetic field will have its main axis perpendicular to the plane of the circuit. So if you have a an electric circle like this or a circuit like this, then the magnetic field will travel perpendicular to it. Now, this magnetic field will decay with the distance, meaning it's going to get weaker as it moves away from the source. And the property of magnetic fields is that they interact with objects in space, and as long as they are not conducting electricity, the magnetic field is unchanged or is unimpeded by it, meaning if we have a piece of plastic or a piece of wood that don't conduct electricity, the magnetic field will just move through it and continue moving in space. But if this magnetic field interacts with a material that conducts electricity, what will happen is that it will convert back into electrical current. So we'll go from an electrical current that converts into magnetic field, and if it meets, for example, in a physics lab with a piece of copper wire, then it will shift back into electrical field. So moving from a physics lab to a neurophysiology lab or to a TMS clinic, this is Tony Barker, who developed the first prototype of TMS in the early 1980s in the UK. And you see that we have a capacitor here and a cable and a coil that is circular, placed on the surface of the head. So we have an electrical current going around this coil, which generates a magnetic field. So the magnetic field moves towards the intracranial space, and it first interacts with the skin, which doesn't conduct electricity, so it moves forward. Then the bone doesn't conduct electricity, moves forward. Then the meninges, which are the skin around the brain, doesn't conduct electricity. CSF, which is a liquid between the brain and these meninges, it moves forward. And then eventually it interacts with cortical neurons. And because neurons do conduct electricity, at this level, the magnetic field will convert into electrical current. It will force neurons to fire, and then it will shape the activity into an entire circuit, in this case, the motor circuit. So while we call it magnetic stimulation, this is a bit of a misnomer. It's actually electrical stimulation of the brain. We just use this trick of physics to be able to very focally stimulate the brain without requiring a craniotomy, without requiring opening the skull to apply this electrical current. So we can do it non-invasively, very safely. And this is currently approved for depression, migraines, OCD, and smoking cessation. Now, anatomy is important because depending on what condition you're treating, you're going to be stimulating very different regions. As I mentioned earlier, know the circuit, know the target. The circuit for these four conditions are different, therefore the targets will be different. For depression, the primary target is the left dorsolateral prefrontal cortex. For OCD is the dorsomedial prefrontal cortex. For migraines is the occipital pole. And for smoking cessation is what we call the ventrolateral prefrontal cortex, going deeper into the insula. So as you can see, to treat different conditions, you're going to be in very different parts of the brain. So you have to know where you are. And one of the good things about TMS is that it's non-invasive. And one of the bad things about TMS is that it's non-invasive. And that is because you have a lot of precision, but because it's non-invasive, you're in the blind. You don't know where you are. I'm not seeing the brain. I'm seeing the skull. I'm seeing the hair. I'm seeing the skin. So I need a way to know where I am. And this way is neuronavigation or stereotaxis, which is a very similar technique to what we use in the operating room. And what it does is we can get a brain scan of a patient. We have an image of their specific individual anatomy, and we can use this technology to co-register the scan with the head of the subject. And this basically allows me to move the coil around the head of that individual, patient or subject, and then looking at the screen, I know exactly where I am in their brains, not just in a generic brain. So I'm able to have this level of specificity. And I can have different types of images of their brain. I will highlight the use of functional connectivity MRI, because it's the one that is getting us to clinical applications more recently. So again, let's go back to the circuit and the target. We know, we discussed very early on, that this area subgenual cingulate is a very critical region for depression. It's hyperactive in depression, and when it goes down, then depression gets better. We know it is connected to parts of the brain like the dorsolateral prefrontal cortex, but the dorsolateral prefrontal cortex is a really large chunk of cortical real estate. It's a very large region. It's also very heterogeneous, very diverse. And there's many parts of the dorsolateral prefrontal cortex that do things that have nothing to do with depression. So it's not enough to know that I am in the dorsal prefrontal cortex. I need to know that I am in parts of the dorsal prefrontal cortex that are relevant for depression for this individual, and that coordinate will be different for another individual. So I need that level of precision again to guide the stimulation. And one way of doing that is using functional connectivity MRI. So I can seed this region, and I can ask, what are the cortical regions, so on the surface of the brain, that are most highly connected with this deeper structure? Basically, what are the windows that are going to give me access to engage this deeper structure? TMS is very shallow. I couldn't use TMS to directly stimulate this area. But if I know on the surface what window gives me the right access, then I'm going to be able to do that optimally. So once I have this map, I know that for this subject, I should be here. And therefore, I can then use stereotaxis and individualized functional connectivity to guide the stimulation. And these are the results from a small open-label trial that we did, 10 patients, where instead of doing the standard TMS for depression, where we don't use neuronavigation, we use this individualized targeting. And what we saw, again, is a small study, 20 patients, open-label, is that 50% of patients didn't respond, but then 50% of patients, the other half, responded. Response in depression means that you got at least 50% or greater improvement. But again, what was interesting here is that all patients who were responders were remitting, meaning all patients who were responders had their depression not just improve 50%, but entirely go away. And this is not typical in the way we see responses to TMS in depression. Most commonly, you may see, without image-guided individualized targeting, that response rates may be in the 50%, but remission is more in the 25%, maybe 30%. So by individualizing the targeting, we managed to get the remission rate to go higher than usual. And to put this in context, these were patients who were very treatment refractory, very sick. They had failed a mean of 7 treatments in just 7 medications that had not worked. So actually, they were kind of in their minds, which is not really true, at the end of the road without too many more options. And again, to contextualize this, these are the results from STAR-D, which was the largest trial in depression that was done in the late 90s, early 2000s, that taught us different things. One of the things that it taught us is that the more treatment resistant you are, the more treatment resistant you are. What this trial did got thousands of patients with depression who were naive to treatment, and they gave them one antidepressant. And if they failed that one, if they got better, they stopped. If they failed, they gave them a second. If they got better, they stopped. If they failed, gave them a third. If they got better, they stopped. If they failed, they gave them a fourth. And what we learned is that if you're naive to treatment and you're giving one antidepressant, 28% of patients remit. But if you fail the first one and they give you a second, only 21% remit. If you fail 2 and they give you a third, 16% of patients remit, and you fail 3 and you're giving a fourth, 7% of patients remit. TMS is approved by the FDA for patients who have failed 1 or more. But in reality, at least in the US, but I think that's reality in most places, we're working to the right of this graph because insurance companies are only approving TMS if you failed 4 or more medications of 2 different classes. So we would expect a remission rate of 7% or lower, much lower, particularly if you failed 7 medications, but we're seeing remission rates of 50% in very sick patients. So to contextualize this, these are atypically high remission rates for patients who are that sick with the power of individualization. Now, I just showed you a small trial. I'm going to show you now data for some much larger trials and how this conceptual approach has entered clinical practice. These are the results from the 3D trial, which they tried to innovate the protocols for stimulation. The first protocols that were approved for stimulation of depression lasted 38 minutes every session. We used 10 Hertz stimulation, meaning 10 pulses per second, over 38 minutes on one day, and we did this every day, Monday through Friday, for about 6 weeks. There was a new protocol called theta burst stimulation. It's not 10 Hertz, it's a more complex set of pulses, but instead of 38 minutes, it lasts 3 minutes. And it has similar effects in the brain, like 10 Hertz or ITBS, they're exciting the target. They're increasing the excitability of the left dorsal prefrontal cortex. So what this Canadian group of 3 different sites asked was, well, can the 38 minutes, can the 3-minute protocol be as effective as the 38-minute protocol? And they showed that indeed that's true. So they were non-inferior. They both got a response rate of about 40% and a remission rate of 20 to 32%. And cerebral stimulation, this very brief 3-minute protocol, was approved by the FDA in 2018. Now, we now have a very brief treatment for depression. It's 3 minutes. What do you do? Patients may drive for 45 minutes, get to your clinic, wait, enter, they sit in the chair, you stimulate for 3 minutes, they're done, they go home. Well, that's one option. The other option is to do more things, given that the treatment is so brief. So instead of 3 minutes, we could do 9 minutes of stimulation, right? We could pack 3 sessions in one. It's still very short, just 9 minutes. But you're packing 3 sessions in one. What if you do that 10 times in a day? Well, you're packing 30 sessions of treatment, which usually happen in the course of 6 weeks, right? Five sessions per week over 6 weeks. But now you're doing that in just 1 day. What if you do that 5 days in a row? Well, now you're packing 8 to 9 months of TMS in just 5 days. A very long set of 5 days, but it's just 5 days. So this is what we call accelerated treatment. And this was proved to not only be very safe, which was a big question since it's such a massive dose of TMS, but also to be not only very effective, but also rapidly effective. So this is what has been called the SANE protocol, the Stanford Neuromodulation Therapy. There's 2 main ingredients to this protocol. One is the massive dose of the accelerated TMS. But the other major ingredient is that they use this individualized functional connectivity guided stimulation. So again, that same imaging protocol to define on a patient-by-patient basis what is the right position for me to place the coil. And these were the results. Again, these were very sick patients, and they observed an 85% response rate and a 78% remission rate. These are not numbers that we are used to in treatment-resistant depression. So it's a bit of a revolution, not only because how effective it is, but because it's rapidly effective, right? This is happening in the course of just 5 days. So this was approved by the FDA in 2022. It's being replicated by other groups. I think one of the caveats for this is that all of this is so effective, the effect sizes are big, so the clinical trials have few patients, enough to detect the signal, but you always want to see this replicated in A, more patients, and B, more sites, particularly when something contradicts your assumptions about what it takes to treat depression. So this is now starting to be replicated in other sites with other patients, including with bipolar depression. And it's actually changing not only how we treat depression, but how we think about depression. In the last couple of years, we've developed a series of technologies that are rapid treatments for depression. We used to think that it takes about 6 weeks or more to treat depression, because that's the time that medications take. And we used to think that this is inherent to the neurobiology of depression. But now we've learned that that's not true. You can use TMS, you can use fMRI-guided TMS in 5 days. ECT we've been using for since the 1930s. Of course, the way we do ECT now is very different than the way we did in the 1930s. The way you get an appendectomy now is very different than you did in the 1930s. But we have also esketamine, which is a pharmacological intervention. It can treat depression in 1 day, including depression with high level of suicidality. We can have neurosteroids that have been approved recently, particularly for postpartum depression. And psychedelics, which are still not approved, but are emerging also, particularly psychedelics integrated with forms of psychotherapy as very rapid, as in a single session, treatment for treatment-resistant depression. Now we have all these technologies and treatments. The question is who should get what and when. And again, this is when it comes not just about developing personalized protocols, but also developing personalized algorithms to make decisions. So this is new from last night. I decided that, well, these days I talk mostly about clinical applications, that given in this context, I wanted to introduce a study that was a little bit of outside of the scope of just the medical domains to talk about cognitive neuroscience and neuroethics at the expense of risking that it's going to extend my talk a little bit, but I thought it would be interesting in this forum to discuss this. So I'll briefly discuss the premises of this study that we did a while back when Aslı and I were still in the same laboratory in Boston. Where we tried to see whether TMS could modulate moral judgments. So there's a premise in moral psychology that in order to emit moral judgments, you need to integrate two things. You need to evaluate intentions, and you need to evaluate the consequences of actions, right? So this may kind of reflect to different models of ethics, deontological paradigms or more utilitarian paradigms that are deontological focus on intentions, the right thing to do, utilitarianism focus on consequences. As long as there's a good outcome for an action, it's a good action. But from a moral judgment, from a moral psychology perspective, there's the integration of the two. Now, there's different brain systems that are processing intentions and consequences. You know, you don't see, you don't touch, you don't measure intentions, so you need a more sophisticated brain function, so-called social cognition or theory of mind, or capacity to infer the contents of other people's minds. I don't touch them, but based on your behavior, based on my assumptions, based on what I know about people, I can, using these circuits for social cognition, infer what are your intentions. And then for consequences, we just use perception and regular cognition because we can see, we can touch the final consequences of actions. Now the question was, if we can engage or modulate or suppress the brain circuits that process social cognition, we may then affect moral judgments because we would basically remove or reduce the impact of evaluation of intentions. And the hypothesis was that we would move moral judgments towards just the evaluation of consequences, towards more utilitarian positions. So to do that, we thought of the social cognition circuitry, which again is a complex one. There's different components: emotion sharing, social perception, mentalizing. Mentalizing is the most relevant here, given that is the one relevant to theory of mind, your capacity to infer the context of other people's minds. So, and the temporal parietal junction, particularly in the right hemisphere, is a particularly relevant hub for this structure. Our colleagues from MIT developed a technique so that we could identify the circuits not at the group level, but at the single patient level. So this is what we call a localizer. And this is the scan for a given patient. So we know that this is where the TPJ, or temporal parietal junction, this is the temporal lobe, this is the parietal lobe, and this is the junction between the two, for each one and every patient. And we could separate aspects of the temporal parietal lobe that have to do with theory of mind, with just other cognitive functions like attention or empathy. So in this context, understanding the circuitry and being able to have technologies that will individualize the targeting for any one individual, we, working with our colleagues from the Harvard Department of Psychology and MIT, developed this experimental paradigm where we have different scenarios that try to have like a two-by-two table where you could have actions where the intentions were either neutral or negative, and you had outcomes that were neutral or negative. So if there was a negative outcome and a negative intention, then it's clear that most patients would say that that's problematic. The more, and we would ask subjects to rate the morality or the acceptability of a given action from 0 to 7. And the problem was when someone had bad intentions, but there was a good outcome, or someone had good intentions, but there was a bad outcome. For example, I may want to sweeten your coffee so that you have a better morning drink, and I might mistakenly put poison into your coffee. My intentions were very good, but the actions are very bad. I may kill you, right? The other way around, it could be that I want to kill you and put poison in your coffee. I just happen to put sugar, and nothing happens. My intentions were very bad. Nothing happened at the end, right? So again, the ontological or utilitarian perspective will judge these different actions differently, given on how if they're weighting more the intentions versus the consequences. And we could set up a paradigm where experimentally we could measure for every individual how they were weighting, how they were judging these intermediate scenarios where there was neutral intentions and bad outcomes, or bad intentions and neutral outcomes. Then we applied inhibitory stimulation to this TPJ, meaning we're able to remove the TPJ out of the equation, meaning we were able to disrupt the social cognition functions, meaning we should be disrupting the capacity to infer the contents of other people's minds. We should be able to inhibit the capacity to judge the intentions. And then we reassess after that interventions how people were judging these actions. And what we observed was that, here you have neutral outcomes and negative outcomes, and you have neutral beliefs and negative beliefs. So, and this is experiment 1, experiment 2. The only difference is that here we did TMS, we created a virtual lesion before so we did first the experimental paradigm, then we stimulated, and then we repeated for experiment 1. For experiment 2, we stimulated while they were doing this paradigm. So we call offline or online, but it's the same general concept. And what we saw is that when we remove the TPJ out of the equation, the neutral outcome negative belief, meaning people who had bad intentions, but there was not a bad outcome, became much more acceptable, meaning we had shifted the moral judgment towards the utilitarian side. We had shifted it for it to rely on the outcomes and evaluate the actual intentions, as we hypothesized. So again, this is not a clinical example, but it is a cognitive neuroscience, a neurophilosophy example of how you can use precision neuromodulation by defining a specific target of a subject, not to treat a condition, but to engage or change moral judgment. And this is teaching us lots of things about the neurobiology of moral decision-making. Of course, it has also clinical implications. These social circuits are disrupted in conditions like autism, behavioral variant frontotemporal dementias, schizophrenia. So we can extract lessons from these that are applied to the clinic, but I think there are lessons from these that are broader than just clinical applications and can make us think about the implications of understanding these mechanistic structures for morality. All right, how much time do I have left?
Actually, you can wrap up in 10 minutes, maybe.
Yeah, perfect. Okay. So we've discussed the anatomy component, right? So how you can use different technologies to individualize the targeting, to bring precision to the where. Now we'll briefly discuss the when, how you can individualize based on physiology and when move from depression to Alzheimer's disease. So we've historically, and I would say still today, conceptualized Alzheimer's disease as, from a cellular and molecular mechanism perspective. What do I mean by that? We thought that Alzheimer's was caused by bad proteins, amyloid and tau, which are misfolding to become toxic, and they misfold in specific brain regions, mostly memory regions. They lead to inflammation, and eventually they lead to neuronal cell death, what we call neurodegeneration. So this has been the prevailing model, and because we had a cellular and molecular model, we have also molecular and cellular therapies, so mostly medications, and more recently immunotherapies. Now, in the last couple of years, we've been able to approve some treatments, so some biologics. These are some antibodies that go to the brain, find the amyloid, and very effectively remove it from the brain. What we observe, though, is that despite being able to do that very effectively, symptoms don't change that much. So that's making us question to what extent this model is actually true. And what we thought would be disease-modifying therapies are just happening to be not so impactful. Now, there's different ways of thinking about Alzheimer's that are more novel, and these are not cellular and molecular, but physiological. And again, if you're thinking about it physiologically, then that would lead not to pharmacology, but to physiologically driven treatments. These are neuromodulation treatments. So we know there's different types of brain waves that have different roles. There are slower delta waves and faster gamma waves. And in Alzheimer's, we see that there's a reduction of the faster waves, gamma waves. There's an increase of the slower gamma waves, particularly around 40 hertz, meaning oscillations that happen 40 times per second. Now, there's been some work happening across the river from my lab at MIT that identify in mice models these 40 hertz rhythms that were problematic, and actually applied visual and auditory stimulation at 40 hertz, meaning flashes of light and sound at 40 hertz treatment. And what they observed, very interestingly, was not only that they could recover the bad physiology, they could improve this deficit in 40 hertz, but they could also improve the memory deficits. Not only that, they could remove the amyloid and tau, and they could lower the inflammatory markers. So, and this was very puzzling because by intervening at the level of physiology, we can engage physiology, this made more sense. We can improve memory, this was very positive. But the fact that we could remove the amyloid and tau, reduce inflammation, and stop neurodegeneration was not necessarily expected. And again, opened the door for this to be really a disease-modifying treatment. We have to move from mice to humans. Things don't always pan out, of course, but there's been this device called GENU that uses these glasses and headphones to apply 40 hertz stimulation. And in humans, this has shown that it can improve brain oscillations. Again, this would be more expected. There's lots of evidence for this with other types of techniques. It could improve memory, but it could also stop the reduction in volume that happens in specific brain regions in Alzheimer's, and it could actually clear the amyloid. So what we saw in rodents, in mice, seems to be happening in humans as well, which is very promising. The phase 2 trials for this technique are ended, and they're about to start phase 3 trials. Now, we want to change an electrical phenomenon, this electrical brainwave. So we could use visual and auditory stimulation, but we may as well just use electrical stimulation. So what we call transcranial alternating current stimulation, and ideally do it at home. So this whole field of transcranial electrical stimulation, these are the least invasive techniques. We basically have a 9-volt battery with 2 electrodes, a cathode and an anode. These are some real-life models, and we can do different things. We can inject a direct current, or we can inject an alternating current. And we'll talk about this specific scenario. By injecting an alternating current, we can engage these frequency-dependent waves. So potentially, if in Alzheimer's we have a reduction of gamma waves, particularly in the 40 hertz space, we could use transcranial alternating stimulation at 40 hertz to increase these 40 hertz rhythms that are a deficit in Alzheimer's patients. And we could do this in an open loop fashion, which is the traditional way, a non-precision medicine way of doing it, meaning we apply 40 hertz stimulation to the brain, regardless of what's happening in the brain. And after doing that, we measure the brain waves and see what impact we had. In a way, the brain remains a black box. We're not measuring, we're not assessing it, we're not taking it into account. Or we could do it in a closed loop fashion, meaning we are using, for example, EEG, which is a technique we use to measure brain waves, to listen to the brain, and then apply these 40 hertz rhythms integrated with these oscillations. And integration here means using the right frequency. For some patients will be 40 hertz, for some 38, for some 43. So individualizing the frequency, but also the timing. Make sure that these oscillations are in phase with the brain oscillations, because we know that we do that, we're going to be much more effective. And this is moving us from the one-size-fits-all to the precision therapeutics. And last, we don't want just to control physiology, but we said that the third component, anatomy, physiology, was controlling the state. So we could do this at rest, but we could also do this in combination with other therapies, right? We can use psychotherapy to control the state. We can use cognitive rehabilitation to control the state. We can use physical therapy in the context of motor rehabilitation to control the state. So these are additional techniques that are not using imaging or neurophysiology, are using behavioral interventions to control the state for any given individual. And lately, we've been able to do this also using virtual reality. So again, these are technologies that allow us to pair virtual reality with neuromodulation to individualize for every given patient, depending on their symptoms, depending on their history, depending on their preferences, specific interventions, it could be like a provocation, stimulation for people with addictions or with OCD, for example, or with PTSD, in order to integrate these behavioral interventions plus the neuromodulation intervention. So we'll finish here as a summary. Precision neuropsychiatry and neuromodulation, we've talked about the need of having patient-specific circuit-based approach, so not just treat syndromes, but the fact that we are moving in this precision medicine framework to precision brain medicine or precision neuromodulation. In the context of circuits, given the anatomy, physiology, and behavior triad, we are going to be individualizing based on anatomy, physiology, and the state. And I've given you a few examples of that, of image-guided TMS, EEG-guided closed-loop TACS, or combination of TACS with cognitive rehabilitations, which could be VR-based. And finally, it's not just about developing individualized protocols, but it's also very important to develop individualized treatment selection algorithms so that in cases that are like the one I showed you earlier for treatment-resistant depression, where we now have many different options, they're all effective at the group level, they're all rapid, but who should get what when? And currently, it's a guess. That's what I do every day when I see my patients. But we want to move from guessing to just having evidence-based, individualized selection algorithms. And we'll leave it here. Thank you very much. And I guess we'll take some questions now or later than what you want.
Thank you so much, John, for this very, very exciting talk. First, I would like to ask the audience if there are questions. Yes, Albert.
Thank you very much for the talk. My name's Albert. I'm a computer scientist, so I'm a little bit interested in the AI-guided therapy choices. I was curious, because you have a lot of individuals with idiosyncratic situations, if you want AI to guide this, what kind of indicators do you store per patient and how do you mine them?
That's a great question. So I didn't go in depth into this, but of course these individualized treatment selection algorithms depend on two things. One, large amounts of high-quality data, and two, AI analytics, right? So the idea here is that we may come up with hypothesis-driven solutions, meaning we may think that there's some specific factors that are relevant, we may want to test them, but we could also be a bit more humble and say there's going to be lots of patterns that we may not think of a priori. Let's get a lot of data, and let's let the data tell us which are the features that are more useful to make these selections. So it's an open question, really. I think we're still trying to figure out. But I think what our work in this space, which is becoming more central as the years move in our specific group, is to get different types of information. So you want to get demographic information, which is more traditional information. You want to get clinical information, that is the more traditional information you find in medical records. But you want to leverage neurotechnology as well to give you information that is newer and potentially more relevant. The problem with traditional clinical information is that I may see a patient once a month, once every 3 months, and have a visit for 20 minutes and ask them, how were you in the last 3 months? And more likely than not, they tell me how they were in the last 2 days. They may not really remember all the details. So the information I get is biased and is of poor quality. We have technology today, there's more people who have access to a smartphone today than people who have access to clean water, which is quite a significant fact, right? So, and this is measuring all sorts of things about me. Measuring when I wake up, what I do when I wake up, where I am, if I'm moving more, if I'm moving less, the temperature, if I'm connecting with lots of people, with fewer people, if I'm reading the news, in what language and what not, if I'm tapping faster, if I'm tapping slow, if I'm making errors, if I'm not making errors, if I'm using some grammatical structures or others. All of this is trackable. I also have a watch. It's measuring my heart rate, my temperature, the skin conductance, the blood oxygen, if I move, if I don't move, when I move. And if you record the video, you're going to have my facial expressions, and you're going to have the physical quality of my voice, and you're going to have the structure of language, what I say and how I say it. All of these technologies are allowing us to capture behavioral information that is much more ecologically valid, meaning it's not me in the clinic asking a patient in my 20 minutes of the visit, how have you been in the last 3 months, but it's me capturing second by second what's happening with that individual. And of course, lots of this information may be absolutely irrelevant, and some of the information may be key to predict outcomes. It may help us identify someone who's about to have a psychotic break before they have a psychotic break, before they even know they have a psychotic break, before a physician knows a psychotic break, and intervene. So a lot of these what we call digital biomarkers or momentary ecological EMA, ecological momentary assessments, are heavily used when building these types of AI models. Of course, and this may come up later, these technologies, while like most of the things in technology, they have lots of good applications and lots of bad applications, right? So they can also, define in very detailed patterns of who you are, what you do, and how you do it. And this could be used for good, this could be used for bad. So how we regulate, if we want to regulate or not, I think it's a big question, and I think so far Europe and the US at least are taking different approaches. You wouldn't be surprised by that. But it's a moving target. We're still trying to define the space of digital biomarkers and what to do with it. But regardless, it's of tremendous potential positive impact in medicine, may have not so positive impact in other areas of science and the law.
Thanks very much. That was very interesting and also optimistic. But one question that I thought, this is a naive question from a lawyer rather than a scientist, but I was thinking about the transcranial stimulation, which was used as kind of a fifth line, when various medications had failed and seemed to be very successful. So, one question is, why is it that the sort of neurotech option is so late in the piece, and you've got to try the medications and fail with them first, because presumably the medications have got side effects, and I wonder if the transcranial stimulation has got less. Is it because it takes more time, or it takes more of the clinician's time to administer it rather than just prescribing medication? Yeah,
so it's a very good and astute observation, because there's no evidence-based medical, clinical, or biological reason why it should be the case. It's strictly an economics reason, right? So, one tablet of an SSRI, which is an antidepressant, maybe 30 cents per day, and this is more expensive. It's also more effective. That's one reason. The other one is the logistics. You can just wake up in the morning, take a shower, have your coffee, and take a pill, or you can structure your day so that every day, Monday through Friday, for several weeks, you spend 30 minutes in a doctor's office. But the reality is that all of these treatments are non-systemic, meaning you don't take a pill that goes to your gut, goes to your bloodstream, and gets to the brain, but also to your lungs, to your liver, to your heart, to the muscles. And actually, it gets to the brain, not just to the parts of the brain that you want to get to, but it gets to the entire brain. That's why drugs tend to be associated with a high number of low, moderate, severe side effects. TMS, it's non-systemic. It goes just to the brain, and in fact, goes just to the part of the brain that you want to engage. So in that way, it's much more specific. That explains its more beneficial side effect profile. And I think many people have argued that it's from a strictly clinical perspective, it should come earlier in the tree of options. It used to be the case, as I mentioned earlier, that at least in the US, you had to, insurance companies wouldn't cover treatment unless patient had failed 4 medications of at least 2 different classes. More recently, the public healthcare insurance in the US, there is one, it's called Medicare, Medicare, allow treatment to happen only if you fail 2 medications. And you're having some of the private payers moving in that direction too. And something that they've realized is that, yes, 30 cents per day of a pill is very cheap, as long as it's effective, because depression is very expensive. And having an expensive, effective treatment for depression at the end of the day is more cost-effective from a health economics perspective than having a cheaper treatment that doesn't really work. And because these treatments are effective, even for the sicker patients, from a strictly health economics perspective, which is the framework in which health insurances think about these issues, they've been moving it to early stages, which from a clinical perspective, which is the space in which we think about things, makes a lot of sense because, again, not only they're very effective, but they're more rapid, and they have fewer side effects. So I would much rather be on TMS than on many medications that may give me all sorts of side effects. Not everyone gets side effects of medications, but it's not uncommon to have side effects.
Thank you.
Any other questions? Yes.
Hello. First of all, thank you for the great talk. So actually, I'm a neuroscientist myself, so I found it particularly interesting to see this clinical side. But what I'm wondering is, with TMS and this kind of stimulations, one limitation I would say is you still cannot get too specific. Like as you said, the nervous system is very heterogeneous, and you have, like in a limited space, different populations of neurons that do different things. Some could be inhibitors, some could be dopaminergic, serotonergic, etc. So my question is, like, how do you think you could get more specific with these techniques? Like, for example, with animal studies, you know, we can use things like optogenetics. Like, obviously, it's limited for human use because you can't simply inject these viruses. But, like, do you think, like, can you project for the future these stimulations could be more specific, or like, is there any studies? Is there any I don't know, trials for this? What do you think?
Yeah, so people have actually been trying to develop viruses to do optogenetics-like interventions in humans. We're not quite there yet. But again, I think the specificity comes back to my very first slide, right? There's different layers of biological resolution. And clearly, when you're talking about TMS and DBS and all these techniques, you're not working at the microscopic, you're working at the mesoscopic, which is, you know, between micro and macroscopic, you have the mesoscopic, which is the level of brain circuits and brain networks. We're not modulating cells, we're modulating populations of cells that are connected with other populations of cells. And this is too specific or too non-specific depending on the problem you want to address. And if the problem you want to address is changing computations that lead to maladaptive behaviors and move them towards other computations that lead to more adaptive behaviors, as long as those computations happening at the level of resolution that your tools have, you may be good to go, right? So yes, I think TMS has many limitations, both in time and space. It's very shallow, so as I said earlier, you're going to go very deep. It may cover an area of 0.5 by 0.5 centimeters to 1 by 1 centimeters, depending on the parameters. There's many, many, many neurons there, and they may do different things. But again, if the final physiological outcome is to change computation at a given level of resolution, from a clinical perspective, you may be good to go. Now, we have new coils that help us work with individualizing the focality. We have also new techniques like DBS, not new techniques, but new approaches to DBS that allow us to, you know, have much finer electrodes where we can individualize the shape of the electric fields in a much more focal and precise and controlled way. Of course, this requires the implantation of an electrode in the brain, so there's issues about that. There's also ways of integrating the stimulation with a specific behavioral intervention. So I could use an electrical stimulation that is more non-specific, but then use a behavioral intervention that activates specific neurons within that area. And by putting the two together, I can gain anatomical precision. So there's certainly, I think, the importance of recognizing your level of resolution, and is this sufficient and appropriate to change, to address the questions or the problems you want to address. I think for many of the questions that we want to address clinically, this may be a reasonable level of resolution. Of course, refining it may lead to advantages, clinical advantages, and there's work in developing technologies and protocols that are trying to move us in that direction.
Okay, actually, I have another question if you have time. So for the Alzheimer's data that you show in mouse with the gamma oscillation, is that tried in humans? And what's the...
Yes, so the first data that I showed was in mice, and that work in mice at MIT in Liu Wei's lab has been translated to humans. So that device, the GENU device, is a neurotechnology setup that has these headphones and glasses that are using visual stimulation and auditory stimulation. And the results have shown that you can improve the deficits in gamma oscillations, improve memory. You can stop the structural changes, the cortical thinning. And if you do PET scans, you can see that you can clear the amyloid depositions. So this has been in phase 2 trials, which generally are smaller trials, randomized controlled trials, but smaller trials. The results were published earlier this year, and that's moving towards a randomized phase 3 trial, which is a much larger confirmatory trial. In our lab, we're using not the visual and auditory stimulation, but the electrical alternating stimulation with a similar purpose. And there's been a few other groups, some in Italy, some in the US, that have been working in similar direction of applying, using neurotechnology, either sensory stimulation or electrical stimulation, to engage these faulty gamma rhythms in Alzheimer's patients and in order to have a disease-modifying treatment.
Very cool, thank you.
Thank you again, Joanne. It was a fantastic talk. I also have questions, but we're out of time. I will ask them later. So now this session is closed, and we have 15 minutes of coffee break.
Thank you.
Welcome back. Now to begin the panel on Neurotechnologies and Human Agency. We would like to invite speakers İnci Ayhan, Aslı Demirtaş Tatlıdede to stage. Eylemcan Aslan will connect through the Zoom. We also kindly invite Başar Bilgiç to stage to moderate the panel.
First of all, thank you, Ozan and Aslı, for this beautiful meeting. Today we gather here to explore and discuss the multifaceted concept of agency, which is in Turkish faili. Agency is not merely about the actions of individuals or groups. It's a more complex concept. Intersects with the social, legal, and ethical dimensions. So in this session, we will discuss this multifaceted concepts of this agency. And we have esteemed speakers here. First, we will start with İnci Ayhan from Bosphorus University. You have the microphone. You can start your presentation. So you.
Invitation, and as well as it's a pleasure to be in such multidisciplinary conferences or seminars and so. And today my talk is going to be in two parts. And in the first part, it's going to be an overall view of what is human agency and just a little bit of introduction. And then on the second part, we are going to be, I'm going to be talking about the studies we've been conducting in the lab, just an overall view rather than a detailed empirical talk. Okay, so the question, oops, sorry. The question is about representationalism versus inactivism. So in the sense that whether we perceive the world, we are passive observers, and just like in the criticism of Dennett in the Cartesian theater, that there's the small man, homunculus in our brain, that is viewing the streamline of consciousness that's been captured via the sensory systems. Or we have bodily animals who are locomoting all the time, so it's rather together with the action that the perceptual systems work. So therefore, there is this bidirectional interaction between the action and perception. And in fact, we know that we learn quite a lot from the environment just by walking or moving our eyes and so on and so forth. So eye movements where we choose to saccade to locations in a scene to obtain more information about that location, in fact, captures quite a lot of information from the point of perceptual systems. And motion parallax. So why do pigeons go around moving their heads all the time is because they do not have a stereoscopic vision because their eyes are on the sides of their heads. So that's why they need motion actually in order to derive depth information, the depth gradient. So these kinds of concepts where motion, in fact, is quite crucial to for object recognition as well as like the derivation of the depth information, has been particularly highlighted by James Gibson in 1950s. Up until that the scientists and vision scientists were studying visual systems where the head is fixated on a chin rest, and while the subjects are fixated on a fixation point on the screen, which does give quite less information about the interaction between the action and the perceptual system. Whereas Gibson emphasizes on the concept like dynamic flux, which is produced by changes in the world or by changes in the viewing position due to the locomotion throughout the world. And just by locomoting around the world, there's quite some information that is highly variable. Obviously, that changes both in the environment as well as in the body of the agent. However, in all of this variability, some characteristic that Gibson is emphasizing would remain constant. And what these invariants are like optic flow. So as I do move, actually, there's this continuous flow of retinal flow of the information on the sidelines, as well as texture gradient that with all of these similar sized objects, those that are nearby would be perceived as bigger and neatly arranged. And as you go further and further, as we see here in the Gustav Caillebotte Paris Street painting, that it gets more homogeneous and start to disappear. And all of these cues that the perceptual system, says Gibson, is used basically in order to change and drive further actions. So optic flow particularly is quite important. It's the pattern of apparent motion of objects, surfaces, and edges in a visual scene caused by the relative motion between an observer and a scene, as we see over here. And look, I mean, optic flow is also quite crucial in order to drive surfaces in the environment. So it is also a very crucial cue to the depth perception itself. And in fact, optic flow is also important to keep balance from systems point of view, as well as like the posture. So for example, if you would try standing on one leg with eyes open and then close your eyes, you are going to realize that keeping your posture and balance would be quite difficult. This is because visual cues, particularly optic flow, also helps the vestibular system as well as the proprioceptive system in order to keep the posture and balance. As well as all of these invariants in the environment and how perception changes and therefore feeds into further chain of visual motor sequences and so. Gibson also talks about affordances. So what are affordances? Gibson says that when I'm looking at this object, not only a passive representation is formed in my brain with respect to the perceptual features of this object, but also automatically my brain starts to compute what kind of interactions can I take with this object. So basically, affordances is what the environment afford to the subject in terms of the action, so it helps action selection. I can grasp that bottle, I can push forward that bottle, I can raise it, and so on and so forth. So there are all sorts of different possibilities that I can interact with that object with. And these interactions, and as well as these possibilities, are affected by two main factors. The first one are obviously the shape of that object, so therefore its perceptual features and so, but it's also about my own morphology in the sense that I do have my fingers, so that's why I can grasp it. So that particular bottle is a climbable object for an ant point of view, whereas it is graspable by myself. So basically our affordance perception also changes with respect to our bodily morphologies. And why affordances and Gibson is so crucial from robotics point of view is that for a robot to interact with an object, it shouldn't necessarily recognize that object. So in fact, we know that there are two main streams in the brain for object recognition, which is the ventral stream that's been feeding into the temporal cortex, and for more like sensory motor interaction and multisensory integration, we have the dorsal stream. And when we are talking about the sensory motor interaction, it has to do with the dorsal functions more than the ventral functions, the ventral stream. So that's why in terms of the robotics guys, and in fact, my coder of my talk, Emre Uğur, is a computer scientist, and he's an expert on robotics. So basically, for those of the researchers that are working on robotics, are mostly focusing on affordance recognition algorithms that do highlight the function of objects rather than their general form, which is mostly the topic for computer vision scientists. And when it comes to action control, prediction is obviously quite important from subject's point of view. It is because we are always living in a way in the past. So because there's this vast amount of energy in the environment, and the energy, let's say that's, we talk about vision, that the light is gonna fall upon my retina, and from that time on, then there would be a transduction to transform this energy into the electrochemical signaling, and then it's gonna go into the subcortical structure like LGN, and then from there into the visual cortex and so on and so forth, that it takes time. So there are neural delays. So that's why by the time I'm gonna be aware of the picture, the environment would have already changed. So that's why in order to catch on with the reality, the subject always makes predictions. And these predictions could be in two ways, like exteroception. So whenever I'm gonna intend to grasp that bottle, that my brain would have already predicted what kind of a sensory outcome would come out of this action. So the tactile sense, as well as like the image that's gonna arise with the bottle inside of my hands, but also proprioceptive prediction that my muscles are gonna stretch, and mechanoreceptors in the muscle and tendons and the joints are also gonna be feeding back the brain how much the limb has in fact moved. Right? And these are all in a very intricate and beautiful relationship in the brain, and according to forward models of action by Wolpert particularly, that these two streams are serving different functions. So when it comes to the sensory outcome prediction, so this has to do with my guessing what kind of a sensory outcome is gonna come after I grasp the bottle. And interestingly, the system would inhibit the sensory outcome that the brain had intended to make the action for. And this is in fact why we cannot tickle ourselves. So when we tickle ourselves, by the time we are going to intend to tickle ourselves, the brain would have already sent the predictory information with regards to what kind of a sensory outcome would come out of it. So therefore, that sensory information after the action is finalized would have been inhibited. Why is this important? By using such prediction, it is possible to cancel out the effects of sensory changes induced by self-motion, so that the environment, so I'm not as, those of the sensory outcomes that had been caused by the agent itself would have been inhibited, so that the agent can focus upon the changes in the environment that is caused by different agents. So therefore, agency is believed to be in the, as a result of such system, in the sense that as my brain predicts with regards to the tactile sense as well as the visual image, after the action is executed, then the reafferent signals from those tactile receptors, as well as the receptors information coming to my retina and so on and so forth, are sent back into the brain. And if this prediction is correct, in other words, the prediction error is small, then I assign myself as the agent of this action. And this is important because a failure in such mechanism, so in other words, in the circuitry, seems to, by particularly Chris Fritz, is believed to underlie the delusions of control in schizophrenia, in which it appears that to the patient that their body is being moved by forces other than their own. So if the prediction error is large, so let's say that that bottle is far away from myself and I'm just looking at the bottle and all of a sudden it's started to rise, that the prediction error is going to be large because my brain didn't predict any effects on the object, and then I will start to look for external forces to explain that effect, such as like, because there are no apparent agents around, that perhaps I'm going to start to think about the surreal forces, extraterritorial forces, and so on and so forth. So the theory of event coding and says that action and perception are in fact encoded by the identical codes within the event file. So in other words, there are sensory associations that before pressing onto a key on a piano, that I would automatically predict the sensory outcome, what kind of a tone I'm gonna hear. So such associations are not only for the sensory features, as had been suggested by Kahneman et al. For the object binding. So when I'm looking at this bottle, there are colors, there are shapes and reflections and so on and so forth. They're all bounded in that object into object files according to Kahneman. And what Hamel is introducing as a novelty is that the action patterns are also in fact involved in such files. And together with one of my master's student, we have been studying the role of time as a sensory feature in the action selection, in the formation of action files. But the interesting thing about these is that after a while, these associations are also start to work in a bidirectional fashion, in the sense that let's think about a baby. A baby enjoys seeing a rotating toy on top of their cradle. And then let's say that it's the sleeping time, so then the parents just switched off the toy. Then what happens? The baby was enjoying the rotation, but now it's been switched off. So the baby will start to select the action that's gonna result that pleasant sensory outcome, in the sense that they will start to rotate themselves. So in a way, those pleasant sensory outcomes will start to drive the action selection in the future. So this is also interesting because it is also the birth of the agency. That Lacan says that, yeah, when the baby is born, that it thinks that we are together with the world, particularly with the caregiver and so on and so forth. And then how the agency develops is through action. The baby then starts to make actions, starts to interact with the environment, and realizes that for some of the actions, the prediction error is small, whereas for some of the other agents doing the actions on the objects, prediction errors are large. So then the baby realizes that some of the effects in the environment, changes in the environment, are caused by their own bodies, and some of the changes are by the others. And this lower level self, that is the first actually level of our very complex social identities that's been developed throughout time, throughout the development, later with the social interactions and so on and so forth. But at the very end, at the very beginning, there's always the body. So everywhere in the world, the self starts with the body. And this is what embodied cognition protagonists say, that cognitive processes are deeply rooted in the body's interactions with the world. From this context, even attention, which is normally seen as a representational concept, is a certain act towards an object. When I am giving my convergent attention into that object, into that water bottle, I am actually acting upon that object. So one of the stream of lines of scientists now do claim that even those abstract or more representation side cognitive processes are all within the action network. And rubber hand illusion is one of those illusions where the synchronous multisensory stimulation do result in the change in body ownership. So as you see over here, in the rubber hand illusion, there's the subject. So there's subject, and in front of the subject, there's a rubber hand, which is not the hand of the subject itself, and there's a block, as you see, a wooden block or so, that my real arm is onto the other side, but I cannot see it. I can only see the rubber hand. What is critical here is the spatiotemporal synchronization together with the stroke of the experimenter, that the experimental will stroke on my hand and onto the rubber hand at the same time, that I'm going to be seeing the rubber hand being stroked, as well as the tactile information coming into my own hand, as we see over here. So now the experimental will start to make the strokes both onto the rubber hand and onto the real hand of the participants, which is invisible to the participant at that moment. And look what? After a very short adaptation period, something like 5 to 10 minutes or so, is enough to induce the illusion that the rubber hand is, in fact, embodied by the subject itself. Shall we? Yes, as we see. What we did in the lab was to combine the rubber hand illusion paradigm together with the tool use paradigm. Tool use is interesting because when you're using longer tools, grabbers and so on and so forth, after a while, after a very short adaptation period, by doing some basic tasks with the tool, as you see onto the right side of my screen over here, and then the subject is being asked to bisect the midline of their arm by their eyes are closed. You see that with the tool using hand is perceptually extended. So in other words, the tool is embedded into the body representation in the brain, which is called as body schema. So in that experiment, we replicated the rubber hand illusion using a tool. So the stroke was on tip of the tool rather than the hand itself. And we, in fact, could present the evidence that it works even with the tools. And in this experiment, we also did quite a lot of manipulations to see how fluid the body image, which is the conscious representation of the body, is in the anorexia, for example. Anorexic patients do feel that their bodies are chubby, let's say, or they're weighted, even though they are not. So there's this change in the body image itself, whereas body schema is mostly used by the proprioceptive system, as well as the vestibular system, which are the more unconscious components of the body representations. From the other side, so what about the proprioceptive prediction, in the sense that the body says, let's say, to the eye muscles to move the muscles 5 degrees to the right, and then the eye in fact makes a saccade 5 degrees to the right, obviously with an error, let's say 5.2 degrees to the right, then the brain is going to compare this feedback coming from the muscles, right? This proprioceptive feedback, in order to adapt into the development where the limbs are growing all the time, so that rather the matrix, the internal matrix system of the body changes all the time, as well as like during the amputation, any injuries or so on and so forth. So it's one of the other very critical prediction systems in the brain. And virtual reality allows us to change the body morphology as well as the affordances, right, by using different kinds of avatars. And in fact, in our lab, we studied the graspability affordance effect using different avatar hands, both like real hand, as you see over here, in order to adapt such avatars and embody them as part of your body. You need just 10 or 15 minutes of adaptation with the basic tasks. So in this task, for example, Tuğçe is looking at her hands, some basic reach and touch tasks, some push forward tasks. And for the graspability affordance, it's pretty critical, like pick and place kind of tasks, that the subject can pick and place the object with the full finger avatar condition, whereas with the capsule hand condition now, the graspability affordance due to the restrictions of the body morphology had been limited. So therefore, we studied the affordance effect and how it changes when we changes the body morphology. And in such experiments, we are using obviously the motion sensors, such as the leap motion. So basically what these motion sensors are doing is to take, with a camera, take the image, video shot of the real hand movements, and by using computational algorithms, then they are taking the whole map of those actions in the real hand in order to project it into the avatar hand. And in this experiment, although affordance effects had been studied by using the computers and so on and so forth in the two-dimensional environments, we could also, by using the motion sensor, we could also study the different phases of the action, the lift-off time, the reaction time for the lift-off, as well as the execution time from the lift-off until the grasp motion had been finalized. So as you see, this was one of the advantages that the motion sensor actually provided us with. And now we are in collaboration with Professor Burak Güçlü from Department of Biomedical Engineering, where one of our students is going to be using this ultra haptics device, which can, as you see over here, make mid-air stimulation at different kinds of levels, so that you are not only it's not only providing a tool for the motion sensor, because it's also integrated with the motion sensor, but you can also give tactile stimulation. And in another project, which was our thesis student with Emre Hoca, we measured the passability affordance effect, both in VR, but it was the COVID time, so we also collected the data on an online gaming platform, where in this study, the avatar's shoulders would have been changed. It would have been either narrower or wider than the subject's shoulder. And what we were particularly interested in was how the instantaneous speed while passing by those gates is gonna change as the subject adapts to their new shoulder widths. And then they would have stopped by and were instructed to press the button. And interestingly, in the study, we had also found out that after the subjects had been adapted into their new shoulder sizes, their perceived arm length would have been also scaled together with their shoulder size. So this was a very interesting finding that we had found. And it's under preparation. Hopefully Safa is gonna write it up. But as well as all of these advantages of the technology, obviously we also have some limitations in the virtual reality. And one of the biggest limitations in the virtual reality is the incompatible depth cues. What do I mean by that? Obviously, the visual reality goggles work in the sense that there would be a slight shift in the left to right images, so that there would be a stereoscopic depth, and this is what gives the subjects actually the three-dimensional percept. However, there are other cues to the depth perception that the brain are using. What are these? Convergence. As the object comes nearby, my eyes converge, and as the object is getting further and further away, my eyes start to look more in parallel. As well as that, there's also accommodation that the lens is gonna change the shape according to how close the fixated object is. So, and unfortunately, in the VR technology now, this incompatibility is not solved. So because different depth cues are signaling different kinds of information, some of the subjects particularly are experiencing motion sickness. It's also true that fusion, the stereoscopic fusion, is sometimes lost from time to time due to head movements. So that's why sometimes this may lead into double vision. And obviously motion sensors that we are using in order to project into the avatar hands and avatar bodies and so on and so forth, they have their limitations in both in space and temporal resolution, that with the fast movements, they are not quick enough to capture the moment and then project into the avatars. And it's also true that you need to work slightly in the narrower space in order to be in their effect area. So this also gives us quite a hard time, basically, in our experiments, because when one of these fails, obviously the sense of reality is also harmed. So this is also another reason, I do guess, that the VR technology, although we're promising at the very beginning, didn't meet, I guess, the expectations as much currently, particularly for the gaming platforms and so on and so forth. And that division, representationalism and inactivism, also, I think, expresses itself in the arts, in the sense that when you are looking throughout the history of arts and how depth had been represented, you first see that obviously the discovery of the perspective in the paintings had been a very big milestone, as we see here in the School of Athens. And then comes Manet. Manet is important because the first collages, Manet is thought to be the first artist who is using collage-like impressions in its paintings, that although there's shadowing and so on and so forth, because the fiber is out of the background, so there's no context, it's somehow as if it had been copied and pasted from somewhere else. And this transforms the image onto the canvas. So rather than being from the centralized view, and also as if we are looking at a depth in the painting, as used by Raphael over here, with the money, the painting has come forward, and together, obviously, with the Cubism, it's also like collage-like an appearance, and with the Jack Pollock, it was like the body movements had been also involved in the paintings, and obviously it's a final stage with the performance arts. The art is now out of the canvas itself, and also the body had been recognized by the artists as well as the scientists. So thank you very much.
Thank you very much. I think we can have questions and your contributions after each talk. So, any of you have any question? Yes.
Microphone's coming.
Just a bit detailed. You were talking about kind of like borning of agency during the early stage of development, while baby is discovering the actions and outcomes and discovering her agency. And you said something about, you referred some words to Lacan, and I missed that point. What was Lacan's contribution to that?
No, there's no contribution of Lacan, but some, researchers as well as some philosophers think that when the baby is born, they do not they do not have an agency, basically. So they think as if they're a whole, actually, with the rest of the world, and particularly with the caregiver, that it takes time, actually, for them to understand that there are different agents, there are different players in the game. And so, for example, seeing the baby on the mirror and acting on it also comes with some time. So when the baby is born, they do not act into their images actually on the mirror. So it also takes time. So they learn, actually. They learn their agency. They learn that there are different agents in the environment and so on and so forth. And this is not like a unified world.
Okay, any other questions? Yes, from Bakış.
Agency is an important concept in psychoanalytic views. And also, according to my readings, I localize agency in the prefrontal lobe, in dorsolateral prefrontal lobe, and it's associated with executive functions. Do you want to say something about this? Because I think I didn't hear about executive functions or prefrontal lobe, which might be associated with your speech. I can, it's not clear maybe, I can repeat it if you want.
Our third speaker, Aslı, she has the answer to that question. So I think maybe Aslı, do you want to answer right now or after your talk? So is it okay for you to wait? So
perhaps we can discuss after Aslı Hoca's talk about that issue.
Okay. Okay. Other questions? I have one question. So is it possible to transfer our illness to your avatars? For example, if I'm a Parkinson's patient, I had a tremor, but I can still pick that stone. Mm-hmm. Sorry?
Hear you.
I'm just asking, is it possible to transfer illness to the avatars? So if I'm a Parkinson patient, I have a tremor, but I can still pick that stone. But I have a tremor. So, I mean, in real life, I cannot do that function precisely, but with avatars, I can do it precisely.
Yes. I think so some treatments, some kind of therapies, yeah. I mean, this also like Ramachandran's phantom limb condition, right, is pretty close to that, that sometimes treatment is possible actually with such therapies and so. And in fact, I guess VR is particularly a very important environment for such treatments and therapies because the sense of reality is quite high. And this is because our body schemas are also very flexible. It's very malleable that even 15 minutes or 10 minutes, 15 minutes adaptations are enough actually to embody the avatars and such. So I do believe that, yes, such treatments are in fact possible in VR. And there are lots of evidence of that in the literature. In fact, although I'm not very familiar in this particular case with the Parkinson's patients.
Yeah. For example, if I use the avatars, so I can drive. But if I do an accident, who will be the guilty? The avatar or the real Parkinson patient?
Sorry, say it again?
So with these avatars,
yeah,
as a Parkinson patient, I can drive the car.
Yes.
But in real life, I cannot.
I see.
So if there will be any accident, who will be the guilty? The avatar or the real Parkinson patient? Maybe this question is to Ozan.
I think the mapping is important, right? How the tremors of the patient are mapped actually into the movements of the avatar. Perhaps the criminal will be the computer scientist at the end. I don't know.
Okay, thank you for your talk. So
yes,
I think we can skip the next speaker. So this talk will be in Turkish. So who needs any translation, please your headphones. So our next speaker, Eylem Can Aslan from Kırklareli University, but she is in the Netherlands right now, and she will talk about relational autonomy and human agency. She will join us via, I think, Zoom. Okay, we are here to listen you. Sizi dinliyoruz şu an.
Herkese merhaba. Umarım sesim geliyordur. Çünkü ben sizi çok kesik kesik duyabildim ilk oturumda da ve şimdi. Siz beni duyabiliyor musunuz?
Evet, biz sizi duyuyoruz.
Bir sıkıntı yok, tamam. Ben çok teşekkür ediyorum düzenleme kuruluna. Aranızda olmayı çok isterdim. Çok önemli bir toplantı bu. Fakat aslında bu konularla da çok alakalı bir projenin bir parçası olarak buradayım. O yüzden ve programlar çakıştığı için aranızda olamadım. Ozan Hoca'ya da özellikle çok teşekkür ediyorum. Hem bu toplantı için hem de onun çalışmalarının bana sağladığı bir ilham ve araştırma olanağı açısından. Çünkü ben yani bu konuların uzmanı değilim aslında. Daha çok nöroteknolojilerin yaratacağı bazı gelişmelerin felsefi açıdan nasıl eline alınabileceği, bize yeni kavramlar yaratmada nasıl etkiler yaratacağına bakıyorum. O yüzden bu konuşmada biraz aslında felsefi düzlemde kalacak. Yani otonomi kavramını felsefi açıdan nöroteknolojilerdeki gelişmelerden hareketle otonomi kavramını nasıl düşünmeliyiz? Ve özellikle de hukukla ilişkisinde nereden alternatif bir bakış geliştirebiliriz? Bunları ele alacağım. Şimdi çünkü şöyle bir şey, büyük teknolojik gelişmeler her zaman için bize bir yarattıkları madde etki sebebiyle dünyayı anlamada ve düzenlemede eski kavramlarımızı değiştirmemize yol açarlar. Yani yenilerini yaratmaya yönelik bir ihtiyacı mutlaka açığa çıkarırlar. Ve nöroteknolojiler de özellikle bu alanda çok güçlü, çok hızlı bir şekilde gelişen bir teknoloji. Ve bu yüzden de köklü kavramsal sorgulamalara ve kavramsal icatlara gerektiriyor. Yani bir önceki yüzyılın sonundaki hani genetik devrimiyle bir benzerlik kurulabilir. Genetik bilimindeki keşiflerin yarattığı büyük etkiyle bağlantı kurulabilir. Hatta daha tarihsel bir perspektiften bakarak sanayi devrimine bile benzetilebilir bu gelişmeler. Çünkü şimdiye kadar hani tıpta ve klinik içi kullanımlarda etkin olsa da artık yavaş yavaş bu nöroteknolojilerin bireysel tüketiciye yöneldiği ve zaten ekonomik, askeri anlamda kullanımlarına konuyu takip edenler aşina. Yani böyle çok kapsamlı bir etkisi, ekonomik, sosyal, kültürel etkisi olacağı için ve bu etki çoktan da başladı aslında. Yani bunu da bir nörolojik devrim olarak adlandıranlar aslında çok yanılmıyorlar. Yani doğru bir ifade ve bir tür aslında hatta bilimsel bir tespit olarak bile bu ifade tıpkı sanayi devrimi gibi belki de oturacak literatüre. Ve Kolombiya Üniversitesi Nöroteknoloji Enstitüsü Direktörü Rafael Yuste'nin insan hakları hukukçusu Jared Genser ve Stephanie Harmon'la birlikte kaleme aldığı 2021 yılında biraz da tabii bu daha popüler olan yayınlarından yani şöyle diyorlar: tarihte ilk kez insan düşüncelerinin teknoloji kullanılarak deşifre edilmesi veya manipüle edilmesine dair gerçek bir ihtimalle karşı karşıyayız. İşte bu ihtimal aslında hem hukukçuları ama aynı zamanda biz felsefecileri sorgulamalara davet ediyor. Bu sorgulamanın alanı çok geniş. Yani haklar, özgürlük, eşitlik gibi kavramlar, hatta toplum algımız, topluma atfettiğimiz ontolojik değer, kolektivite terimi, kavramı, buradan beden, zihin, özne, birey, hatta insan kavramının kendisi, kendilik kavramı, özdeşlik gibi kavramların hepsinde aslında gözden geçirilecek yeni birçok mevzu var. Ben bu sunumda hani faillik ve daha çok da otonomi kavramı üzerinde duracağım. Çünkü bunlara da etkisi söz konusu. Ve şunu savunmaya çalışacağım. Nöroteknolojileri değerlendirirken mevcut etkisi hala süren liberal otonomi kavramı yetersiz kalabiliyor. Ve özellikle Jennifer Nedelsky, Catriona McKenzie ve Natalie Stolyar gibi feministlerin ilişkisel otonomi, relational otonomy kavramının hem bu teknolojilerin yaratacağı risklere ve sorunlu alanlarla yüzleşmede hem de daha pozitif öneriler gelişmede çok daha etkili olabileceğini düşünüyorum. Şimdi öncelikle ben klasik ya da liberal otonomi kavramıyla neyi kastettiğimi biraz açıklık getireyim. Kastettiğim belli bir birey ontolojisine temel alan ve bu bireyin kendine yeterliğini, kendi güçleri üzerindeki egemenliğini, rasyonel öz yönetim kapasitesini ve bağımsızlığını öne çıkaran anlayış. Yani bu otonomi anlayışında, klasik otonomi anlayışında bağımsızlık kavramı çok önemli bir yere oturuyor. Belki daha doğru bir ifadeyle bireyci otonomi kavramı da diyebiliriz buna. Fakat bu anlayışta birey, onu tam da o birey yapan tüm ilişki ağlarından, ekonomik, tarihsel, kültürel olduğu kadar, kamusal olduğu kadar aynı zamanda özel ilişki ağlarından da soyutlanıp mutlaklaştırılıyor ve kendinde bir amaç olarak tasavvur ediliyor. Geleneksel hukuk kuramındaki sui juris kavramı, yani sadece kendi hakkına tabi olup başka hiçbir kuvvete tabi olmayan özne kavramının bununla çok yakından bir alakası var. Bu anlayışın ama tarihsel ontolojisine baktığımızda aslında karşımıza çıkan aslında belli bir birey, belli varlıklar oluyor. Yani işte hani biraz karikatürleştirerek söylersek mülk sahibi beyaz erkek aslında bu otonom bireyden anlaşılan. Ve bunun karşısında bu ontolojinin kurgusal yönünü yahut da iktidarın özneleştirici dispozitifleriyle ilişkisini görmek, yaşamın çok daha geniş, çoklu ve karmaşık ve karşılıklı bağımlılıklara dayanan kısmını görmek, aslında kimsenin tamamen bağımsız veya sui juris, yani yalnızca kendi hakkına tabi olamayacağını, olmadığını, önemli olanın da kaçınılmaz karşılıklı bağımlılık ilişkilerinde, yani mutual interdependence kastettiğim kavram, herkes için özgürleştirici hale getirmek bu bağımlılık ilişkilerini, karşılıklı bağımlılık ilişkilerini. Bunu vurgulamak istiyorum. Şimdi neden peki? Yani nöroteknolojilerle ilişkili olarak bu kavramı eleştirmek neden önemli? Çünkü hani şöyle de düşünebiliriz. Yani hani bu çok ya artık çok dile getirilen bir eleştiri. Yani biz artık çok daha farklı perspektiflerden bakan, hem feminist gelenekten daha başka yerlerden de ilişkisel söylemlerden beslenen yeni açılımlara zaten aşinayız. Niye şimdi buradan hani bunun ne gibi faydası olabilir diye akla bir soru gelebilir. Şöyle bir önemi var hala. Çünkü nöroteknolojilerin yarattığı risklere karşı çeşitli hukuki ya da etik açıdan yapılan önerilerde, geliştirilen önermelerde aslında hala bu klasik otonomi anlayışının ve bununla ilişkili olarak özgür irade kavramının hala etkin olarak kullanıldığına, başvurulduğuna ve bunun hiç de sorgulanmadığını görebiliyoruz. Ve bu tür bir bağımsızlıkçı ve bireyci otonomi anlayışı, örneğin özgür irade hakkı önerisinde, Nöro Haklar Vakfı'nın 5 nöro hak önerisinin içerisinde yer alan bir hak, yahut kişi özdeşliği hakkında, the right to personal identity, bunlar da çok hissedilebiliyor, etkin olabiliyor. Bir başka örnek vermek gerekirse Nöro Haklar Vakfı'ndan başka, OECD'nin nöroteknolojilerde sorumluluk sahibi inovasyonlar için 2019 tarihli bir tavsiye metni var. Burada da mesela otonomi kavramının kullanışına bakıldığında evet, bireylerin bilişsel özgürlüğü, cognitive liberty, düşünce özgürlüğü ve mahremiyetinin yanı sıra ayrıca bir otonomi vurgusu yapılıyor. Ama buradaki otonomi vurgusunun içeriğine baktığımızda ve seçme özgürlüğüyle, freedom of choice'la çok özdeş bir şekilde kullanılıyor. Hatta tanımı gibi veriliyor. Burada da aslında bu bahsettiğimiz bağımsızlıkçı otonomi anlayışı mevcut. Yahut son bir örnek olarak nöro haklar önerilerine kuşkuyla baksa da, yani böyle bir hani özgür irade hakkı gibi bir hakka ihtiyaç duymadığımızı, bunun uzun vadede gerçekleşebilecek bir öneri olmadığını düşünse de mesela ve mevcut insan haklarının güçlendirilmesi gerektiğini bu yüzden savunuyor. Christoph Pavlis'in bilişsel özgürlükle aynı anlamda kullandığı zihinsel belirlenim, mental self-determination kavramına aslında bu klasik otonomi kavramıyla çok yakından bağlı. Yani bu Pavlis'in yorumunda da bir tür kayıtsızlık özgürlüğünü, freedom of indifference, bunu çağrıştıran türden bir tasavvur ve bireyci bir otonomi anlayışı var ki zaten şöyle bir ifadesi var. Kişinin kendi zihni üzerindeki egemenliği, yani an individual sovereignty over her mind diyor. Yani zaten hani mevcut insan hakları paradigmasına da zaten eleştirel bakılmadığı sürece belki de zaten bu da kaçınılmaz bir sonuç oluyor. Fakat bunları söylemekle birlikte bu savunuları yani böyle bir korkuluk haline getirip zayıf yönlerini sadece ele almak da çok doğru bir yaklaşım olmayacaktır. Bu bireyci otonomi savunusunun nöro haklarla ve nöroteknolojilerle ilişkili olarak çok önemli bir yanı var. Ön açıcı yanı var. O da şu ki ahlaki ve cezai sorumluluklardan tartışmayı, yani bu nöroteknolojilerle ilgili olan tartışmayı ahlaki ve cezai sorumluluk boyutundan özgürlüklere doğru taşıyorlar. Yani şimdi felsefi ve etik bir sorun olarak özgür irade tartışması çok eski aslında. Ama bunun nöroteknolojilere ilişkilendirilmesi tabii ki bu teknolojilerin gelişimiyle de alakalı olarak 2000'li yılların başlarında artıyor. Ama bu yıllardaki ilk tartışmalara baktığımızda bu faillik, kime faillik atfedeceğiz işte mevzusu. Buralarda işte Roskis'in, Moreno'nun bu alanda çalışmış ilk isimlerin çalışmalarına baktığımızda hep bu ahlaki sorumluluk ve cezai sorumluluk kavramları öne çıkıyor. Yani çünkü karar alma ve bu nöroteknolojiler karar alma ve bu kararları uygulama süreçlerini karmaşıklaştırıyor ve sorumluluk atfedilebilecek tek bir fail arayışını da sekteye uğratıyor. Tabii ki bu durumun da hukuki ve toplumsal sonuçları büyük oluyor. Yani dolayısıyla meselenin de tabii öncelikle buralardan hareketle tartışılması hiç şaşırtıcı değil. Ama işte bu son dönemde bu faillik meselesine yaklaşım sorumluluk zemininden haklar zeminine geçiyor. Ve nöroteknolojik risklere karşı ki bunların bazıları tehdit olabilecek düzeyde görülüyor. Bireyin özgürlüğüne odaklanan incelemeler, vurgular, kaygılar artıyor. Burada kişiye başkaları tarafından karar ve davranış sorumluluğu yüklenmesinden ziyade artık onun kendisine dair öz değerlendirmesine, karar ve davranışlarını kendisine atfedebilme kapasitesine odaklanan bir bakış ortaya çıkıyor ki aslında bu çok önemli bir atılım. Bir de şu var, şunu da ekleyeyim. Yani şimdi bu bağımsızlıkçı söylem çok bu alanda çalışan bilim insanlarının geliştirdiği bir bakış olduğundan da şüphe duyuyorum ben. Çünkü şöyle bir şey, geçen yıl Ozan Erözden'in ve Elif Güzeci'nin sayesinde Werner Herzog'un Theater of Thought'unun özel gösterimine katılma şansım olmuştu İstanbul'da yapılan. Bu belgesel Nörohaklar Vakfı ile birlikte yapılmış. Bu nöroteknolojilerdeki gelişmeleri ele alan bir belgeseldi. Ve belgeselin sonunda da Rafael Yuste ile özel bir söyleşi olmuştu. Orada Rafael Yuste şunu yani ben bu hak formülasyonlarının nasıl yapıldığına dair merak ettiğim bir şeyi sormuştum. Ve şöyle bir şey demişti. Yani biz bir hani hukukçu ekibimiz var. Ki zaten aslında onlardan biri de çok etkin, Amerika'da çok etkin olan bir insan hakları hukukçusu. Sıklıkla hani başka konularda da öne çıkan bir isim. Biz nöroteknolojilerin yaratacağı risklere doğrudan bildiğimiz için bunları ekiplerimizle paylaşıyoruz, aktarıyoruz. Elbette ki birlikte konuşup tartışıyoruz ama nihayetinde bunların formülasyonlarını hukukçular yapıyor demişti. Tabii manifesto niteliğinde birlikte yazılar da yazıyorlar. Yahut da hiç liberal bir geleneğe sahip olmayan Latin Amerika gibi ülkelerde bu liberal söylemler, nöroteknolojilerin risklerine dikkat çeken söylemler etkili olabiliyor. Hani böyle durumlar var. Ama açıkçası ben biraz burada hukukçularla ilgili bir sorunun daha fazla olduğunu düşünüyorum. Bu yüzden de hani söz konusu durum geleneksel hukukçuların alternatif bir zihin anlayışına aşina olmamalarından yahut klasik otonomi ve özgür iradeyi bir hukuk kaidesi olarak varsaymak zorunda hissetmelerinden kendilerini kaynaklanıyor olabilir. İşte tam da bu yüzden hani bu alışılmış hukukun dışındaki bakışlar özellikle çok önemli oluyor. Yani yine Ozan Hoca'nın 2022 tarihli bir makalesinde insan makine arayüzleri ve insan hakları başlıklı çalışmasında yani şöyle bir vurgusu var. İnsan hakları hukukunun ardındaki dualist kabulleri sorgulamadan ve yeni bir temel aramadan aslında bu risklere karşı nöroteknolojinin yaratacağı risklere yönelik çözüm arayışları da etkisiz kalabilir diye bir uyarısı var. Yine benzer bir eleştiri nöroetik tartışmalarındaki kişi özdeşliğine bakışla ilgili François Baylis'ten geliyor. O da kişi özdeşliğini ilişkisel ve dinamik bir şekilde kavramadığımız sürece derin beyin uyarımının teknolojisinin özdeşliğe tehdit oluşturacağı iddiası sorunlu hale gelebilir diye bir bakışı var. Yahut Catriona McKenzie, Mary Walker, bu ikisinin zaten Relational Autonomy diye bir derlemeleri de var. Otantiklik nosyonunu sorunsallaştırıyorlar ve bu nosyonun özdeşlik ile otonomi arasındaki çoklu dinamikleri gözden kaçırdığını, hakiki, içsel, saf, bozulmamış bir kendilik fikrinin makul olmadığını ve bunun yerine kişinin bedenli konumlanmışlığına, embodied state noktasına dikkate almak gerektiğini söylüyorlar. Ki bu otonomiyi ilişkisel kavrayan isimlerde bu bedensel konumlanmışlık çok önemli bir vurgu. Hani düşünce her zaman için bedensel konumlanmışlığın etkileşimsel, bağlantısal, iletişimsel bir ürünü veya eşlikçisi. Bu anlamda onu bir mülkiyet olarak kavramak, karşılıklı bağımlılık ilişkileri içerisinde gelişen etkin ve hareketli yanını gözden kaçırıyor. Yani düşünce bir etkinlik ve hareket. Otonomi de bağımsızlık demek değil aslında. Yani burada şöyle bir şey var. Otonomi kavramından vazgeçelim gibi bir öneri söz konusu değil. Ama tam tersine bu otonominin varoluşumuzun zorunlu koşulu olan karşılıklı bağımlılık ilişkileri içerisinde ancak mümkün olabileceğini ve herkes için mümkün olabileceğini söylemek aslında. Tek başına ilişkisel belirlenimlerden bağımsızlaşarak otonom ve hak sahibi olamayacağımıza dair bir vurgu. Çünkü şöyle bir şey var, yani neden bu sui juris eksenli, bağımsızlıkçı otonomi kavramı, neden sorunu? Bir de şu var, yani hiçbir zaman aslında böyle bir hayat mümkün değil. Yani relations of care dediğimiz o bakım ve ilgi ilişkileri ya da Marksist bir terminolojisiyle söylersek yeniden üretim ilişkileri olmadan hayat devam etmiyor. Ve bu bağımsızlıkçı otonomi kavrayışında bu ilişkiler gizleniyor, mistifiye ediliyor. Yine hani biraz Marksist bir terminoloji olacak ama mistifiye ediliyor ve gerçekte yalnızca karşılıklı bağımlılık ilişkileri içerisinde elde edilebilecek olan otonomi bir tarafa mal ediliyor ve diğer ilişkinin diğer tarafları bu özgürleşme olanağından dışlanıyor ve bir meşrulaştırma stratejisi olarak da işliyor bu otonomi kavramı. Ve kartezyen bir bakışta ben bilinci, öncelliğini, düşüncenin etkileşimden ve iletişimden bağışık, tek bir zihin içinde başlayıp biten hareketsiz bir şey, think olduğuna dair, zihnin de bu şeyin tek sahibi ve kontrolü olduğuna dair bir kavrayış hala etkili oluyor. Yani bunu çok kısaca bir parantez, yani bunu hala eleştirmek gerekiyor mu diye bazen felsefeciler söylüyor. Evet, eleştirmek gerekiyor çünkü hala toplumsal yaşama dair getirilen önerilerde, norm önerilerinde bu ontolojiyi görüyorsunuz. Ama bunun dışında işte bir başka alternatif, işte ilişkisel otonomi dediğimiz, yani bu işte sadece bu yani feminist ekolün bir açılımı, daha eskiden başka felsefede, düşünce tarihinde ya da daha genel olarak elbette ilişki kurulabilecek başka düşünürler, ekoller, girişimler elbette var. Ama bunu özellikle bir hukuki açıdan geliştiren düşünce feministler. Ve burada artık o Kant'la birlikte başlayan modern insan hakları söyleminden ciddi bir uzaklaşma söz konusu. Sadece aslında modern söylemden değil, bu Antik Yunan'da ve Roma'da da etkili olmuş olan bir söylem. Ve o yüzden hani bu söylemi sarsanların feministler olması da hiç şaşırtıcı değil. Çünkü bu tarih boyunca gelen bir belli bir süreklilik var bu dominasyonda. Ama bu terimin bir şemsiye terimi olduğunu ve farklı perspektifleri içerisinde barındırdığını da vurgulamak gerekiyor. Yani Mackenzie ve Stolyar'ın kendisinden bir alıntı yapacağım. Bu bahsettiğim Relational Autonomy derlemesine yazdıkları girişten. Yani bu birçok perspektiften bu ilişkisel otonomi kavramı geliştiriliyor. Biyoetikte çok etkili bu arada. Yani biyoetikte ilişkisel otonomi üzerinden sorunlu, riskli konuları ele alan çalışmalar var. Bu perspektifler ortak bir kabule dayanıyorlar. O da kişilerin toplumsal olarak bedenlenmiş oldukları ve faillerin özdeşliklerinin bu sosyal ilişkiler içerisinde, sosyal ilişkiler bağlamı içerisinde oluştuğu ve etnisite, toplumsal cinsiyet, ırk, sınıf gibi çok çeşitli sosyal belirlemelerin kesişimlerinin bir karmaşık bir birleşmesi olduğunu kabul ediyorlar. Dolayısıyla da ilişkisel otonomi anlayışının odağı bu özneler arası kendilik kavramının ve özdeşlik kavramlarının bu özneler arası ve toplumsal dinamiklerini analiz etmek. Bu analizleri de bireylerin otonomisi ve failliği açısından bunların faydası için geliştirmek. Şimdi özellikle tabii şeyde anmak gerekiyor, Jennifer Nadolsky'nin katkısını. Aslında zaten bu relational otonominin tümüyle feminist bir perspektiften ve hukuk alanında geliştiren isim olarak kabul ediliyor. 1980'lerin sonlarına kadar eskiye gidiyor bu kavramı geliştirmesi. Reconceiving Autonomy diye bir makalesi var. Fakat asıl onun teorisi en derli toplu, en böyle billurlaşmış haliyle 2013 tarihli Law's Relations, A Relational Theory of Self, Autonomy and Law isimli hukukun ilişkileri, kendilik, otonomi ve hukuka dair ilişkisel bir teori isimli Oxford UP'den çıkan kitabında karşımıza çıkıyor. Bu arada 2023'te de çok yeni, henüz onu okuma şansım olmadı. Ama biraz çalışmaları biraz daha farklı bir alana kaydı. Önemli bir çalışmaya imza attılar Tom Mallison'la birlikte. Part-Time for All, A Care Manifesto. Herkes için part-time. Bakım, ilgi, bu sözcüğü sadece tek bir Türkçe kelimeyle karşılamak çok zor. Bakım manifestosu diyebiliriz. Şöyle bir tezleri var. Yani bakım dediğimiz üretim ilişkisini aslında yayarsak bunun üstlenme şeyini işten özgürleşmekte çok daha mümkün olacak. Evet, yani toparlıyorum ben. Bilmiyorum, çok uzattım mı? Süreye bakmadan başladım çünkü. Yani özellikle Nadolsky'nin geliştirdiği haliyle bu ilişkisel otonomi kavramında kendilik, ben dediğimiz nosyonlar tam da bunların yani ontolojik oluşumları ilişkisel olduğu için bunları anlamaya dair bizim kavramlarımızın da ilişkisel olması yönünde. Onun kitabından bir alıntıyla söylersem şöyle diyor. Hukuk yetişkin insan varlıklarını karakterize eden bağımsızlık ve sorumlulukla ilgili çeşitli varsayımlar yapar. Ve insanların ifade özgürlüğü, ifade ve örgütlenme özgürlüğü gibi çeşitli haklara sahip olduğunu belirtir. Eğer bu haklar otonomi fakültesinin yetisinin gelişmesine dayandırılacaksa bunun tek olanağı bu otonominin mümkün olabileceği ilişkilerinin de geliştirilmesidir. Çok kötü çevirdim, kusura bakmayın. Yani şunu söylüyor, biz eğer gerçekten otonomiyi sağlamak istiyorsak öncelikle bu otonomiyi mümkün kılacak ilişkileri geliştirmeliyiz. Öncelikle bu ilişkileri özgürleştirmeliyiz. Aslında nihayetinde nasıl formüle edilirse edilsin, önemli olan kavrayışın kendisi. Yani ben şunu demek istemedim bu sunum boyunca. Otonomi kavramını kullanmayalım, ilişkisel otonomi diyelim. Önerdiğim şey bu değil. Ne terim kullanırsak kullanalım, sadece otonomi de diyebiliriz. Bunu nasıl kavruyoruz ve bu nasıl yaşanıyor? Biz bu kavramları nasıl deneyimliyoruz? Asıl olan bu. Çünkü yani bu öneriler içerisinde tırnak içerisinde liberal diyebileceğimiz gelenekten gelen çok önemli, çok ön açıcı öneriler de var. Yani mesela psikolojik süreklilik hakkı önemli bir tehlikeye bence parmak basıyor. Çok yani anlayabildiğim kadarıyla, konuyu takip edebildiğim kadarıyla. Ama biz bunu nasıl anlayacağız? Yani psikolojik süreklilik hakkını nereden anlayacağız? Daha doğrusu psikolojik sürekliliği nereden anlayacağız? İlişkisel bir düzlemden mi? Yoksa bireysel, atomik bir anlayışa dayanan bir düzlemden mi? Yahut kişi özdeşliği hakkını nasıl anlayacağız? Biz kişinin kendisiyle özdeşliğini, yaşadığı ilişkiler olmadan, bu ilişkileri dikkate almadan nasıl kavrayabiliriz? Sadece nöroteknolojilerle ilişkili olarak değil, daha geniş düzlemde böyle bir sorun ortaya çıkıyor. Ve dediğim gibi ethics of care'de, biyoetikte bu kavram zaten başvurulan bir kavram. Güncel birçok çalışma var. Çok kısa bir araştırmayla bile bunlar fark edilecektir. Ben sadece bu kavramın nöroteknolojileri ele alırken de daha fazla başvurulabilecek bir kavram olduğunu vurgulamak istedim. Çok teşekkür ediyorum. Umarım kesintisiz bir şekilde duyabildiniz beni. Sağ olun.
Teşekkür ediyoruz. Gayet güzel duyduk sesinizi. Ben şimdi salondan soru ve katkı var mı? Evet, sorular var buradan. Siz isterseniz Türkçe devam edelim bu kısımda.
Tamamdır. Eylem Hocam, teşekkürler sunumunuz için. Ben açıkçası kafamı biraz açmak için bu soruyu soruyorum. Bu ilişkisel otonomiden o zaman kastettiğimiz aslında Marksist bir perspektiften bakarsak üretim ilişkilerini ya da yeniden üretim dediğimiz olguyu kapsamıyor. Bu durumda liberal otonomiden ya da neoliberal dönemdeki birey inşasından nasıl bir farkı olduğunu anlamadım. Yani onu tam olarak kafamda oturtamadım. Bir de sorumluluk rejiminden haklar rejimine bu nöroteknolojilerle hukuk alanında bir geçiş olduğundan bahsettiniz. Buradaki ama o zaman sorumluluk rejimiyle haklar rejiminden kastımız da sanırım altın çağdaki bir kolektif hak tanımından ziyade yine bir bireysel hak anlatısı üzerinden mi yürümekte? Bunu merak etmekteyim.
Teşekkür ederim soru için. Yani ilişkisel otonomi perspektifinden nöroetik ya da tıp etiği çalışan isimlerin hepsi Marksist değil. Böyle bir bağlantı bence zorunlu da değil. Benim sadece kendi okuma birikimimin bir parçası olduğu için o terimi kullandım. Yoksa doğrudan böyle bir özdeşlik yok ama liberal söylemi eleştirme konusunda bir ortaklık, bir yakınlık, kesişim, karşılaşma var. Ayrıca hani Marksizm içerisinden, yani Marksizme de bu feminist ekolden getirilen bir sürü yenilik var, eleştirel yaklaşımlar da var. Diğer sorunuzu anlayabildiğim kadarıyla şöyle, yani çok büyük bir fark var açıkçası. Şöyle ki mesela şeyi düşünelim. Yani politik, özgür vatandaş imgesine, yani bu düşünce tarihinde etkin olan, yani daha modern döneme gelmeden bile önce. Burada nedir? Mesela nedir? Politikaya atfedilen ödem nedir? Özel alandan kurtulmak. Çünkü o ev içi hane ilişkileri, temizlik, bakım, bunlar kötü işlerdir. Bunlar zaman kaybıdır. Bunlar hayatın kendisi değildir. Bunlardan uzaklaşarak özgürleşilir, yurttaş olunur ve aktif olunur. Bu bakış yani hep hakim oldu antik dönemde. Hatta bu bakışı yeniden o modeli yeniden alıp yeni politik modern dönem için, bizler için yeni özgürlük olanakları öneren isimlerde de etkili oldu. Ben mesela Arendt'in politik özgürlük anlayışında hala bu klasik otonomi anlayışının etkisi olduğunu düşünüyorum. Yahut Kant'ın bireyi, evet, aklını kullanan insan. Ama o akıl yalnızca o insana ait bir akıl mı? O akıl nasıl oluşuyor? O aklın ötekisi kim? Irk sorununu ele almadan, Kant'ın ırk meselesi üzerine yazdıklarına dikkate almadan biz nasıl bu aklı düşüneceğiz ya da değer atfedeceğiz? Çok büyük bir fark var bence bu klasik otonomi anlayışıyla feministlerin otonomi anlayışı arasında. Diğerinde biz ev içine artık yahut bu üretimi, temizliği, bulaşığı, yaptığımız işleri aşağılık işler olarak görmüyoruz. Tam tersine hayatın kendisi olarak görmeye başlıyoruz. Yahut bir zayıflık olarak, mesela bir duygusallığı, duyguları bir zayıflık olarak görmüyoruz. Bu tür ikici bakışlardan bakılmıyor artık. Yani sarih, dış etkilerden bağımsız, güçlü akıl ve duygusal, zayıf, dış etkilere açık, duygusal yön, beden şeklinde artık bakılmıyor.
Şimdi diğer soruları da alalım.
Teşekkür ediyorum. Ben de ceza hukukçusuyum. Dolayısıyla o bakış açısıyla bir soru soracağım. Şimdi daha önceden de bu otonomi anlayışına, yani ceza hukukunun sorumluluk temeli olan otonomi anlayışına, liberal anlayışa getirilmiş olan eleştiriler vardı. 1920'lerde mesela pozitivistlerin getirdiği eleştiri de bu yöndeydi. Ve bunun sonucunda pozitivistlerin önerisi bireysel sorumluluğu ortadan kaldırıp hayat tarzı sorumluluğu, hayat tarzı kusuru üzerine kurgulanmış bir ceza sorumluluğu anlayışı getirmek oldu. Ancak bu yarardan çok zarar getireceği düşüncesiyle sonuç itibariyle sistem tarafından reddedildi. Pozitivistlerin çoğu katkısı ceza hukukuna girdi ama sorumluluk anlayışının temelini değiştiremediler. Bunun sebebi de şu oluyor. Sonuç itibariyle bu bir toplumsal bir kurgu, hukuk dediğimiz şey ve eninde sonunda bütün sorumluluk anlayışını değiştirmenin maliyetinin bundan getirilecek olan kazanıma göre düşük kalması gerekiyor ki kendisini geliştirebilsin. Günümüzde bu etkileşimsel otonomi anlayışının yaratmış olduğu çok büyük kazanımlar var. Özellikle cinsel suçlar bağlamında işte ne bileyim rıza kavramının, onam kavramının veya işte meşru savunma veya haksız tahrik gibi konularda feminist eleştiriden getiren çok güzel kazanımlarla karşı karşıyayız ama faile ilişkin sorumluluk temelini yeni bir paradigmaya oturtabilmek için mevcut güvencelerin ortadan kaldırılmadan yeni bir özgürlük temelinde şeyi oturtulması gerekiyor. Yani topluma ait olan sorumluluğun ne şekilde dağıtılacağı ve üstlenileceği ile ilgili net bir sistemsel sonuca ihtiyacımız olduğunu düşünüyorum. Bunu nasıl üretebilir bu fikir, bu teori? Bunu sormak istiyorum.
Diğer oturumların çok sarkmaması için Eylem Hocam kısa cevap alırsak diğer soruları da alacağız çünkü.
Tabii. Çok duyabildiğimi söyleyemeyeceğim ama genel olarak anladım. Yanlış bir şey de söylemeyeyim. Çok kısaca şunu belirteyim. Cezai sorumluluk kavramına hiç yani bu tür bir kavrama başvurmadan çok daha farklı bir şekilde adaleti düşünülebilir. Bu yönde zaten girişimler de var ve özgür irade kavramını reddettiğimizde de aslında kastetme kavramını reddetmiş olmuyoruz. Yani biz yaptıklarımızın bilincindeyiz. Mevzu o bilincin ötesine ulaşabiliyor muyuz? Buradan başlıyor. Ve yani çok farklı açılımlar var bu alanda, arayışlar var. Onarıcı adalet arayışını, tabii ben şimdi böyle burada bunların üzerine konuşmak çok doğru değil. Orada bunlar üzerine konuşabilecek yetkin hukukçular var. Ama adaleti ve reformu biz korurken illa sorumluluk kavramına ihtiyaç duymayabiliriz. Bu sadece bir hani öyle bir challenge olarak masada durabilir.
Peki. Son soruyu Albert Ali Hoca'dan alalım.
Çok teşekkürler. Ali benim ismim. Ben bir yapay zekacıyım. Onun için o taraftan bir soru sormak istiyorum. Bu yapay zekanın yetkinlikleri geliştikçe insan yapay zeka hibritleriyle karşı karşıya kalacağız. Yani karar verme süreçlerine gittikçe yaklaşıyor yapay zeka. Ve insanlar bunları karar verme sürecinde kullanmaya başlıyorlar. Bunun bir etkisi içinde bulunduğumuz toplumun da hızlıca bir değişime giriyor olması. Yani iletişim teknolojisiyle bir kere zaten çok daha dinamik bir hale aldı. O bağlantılar dediğimiz şey artık sabit değil, çok hızlı değişiyor. Normlar da değişiyor. Yapay zekanın bu şekilde gelişimi nasıl bir dikkate almamız lazım? Yani otomasyonda ya da otonom birey düşüncesi bireyin kendi algısını da değiştirebilir ama davranışı da değiştirebilir.
Ben doğrudan yapay zeka çalışmıyorum. Çok alakalı, nöroteknolojilerle çok alakalı bir alan elbette. Çünkü o teknolojilerin gelişiminde de rol oynuyor. Ama yapay zeka başlı başına ayrı bir araştırma konusu açıkçası. Yani sadece şunu söyleyebilirim. Zaten insan zihni aslında hiçbir zaman şey olmamıştı. Yani korkuları, yani ben biraz tekno-optimist biriyim. Yani tabii çok bireysel bir görüşüm bu benim. Çok bilimsel olarak bunu söylemiyorum. Ben o kadar korkmuyorum. Biz zaten hani bir şey varsayıyoruz. Yani böyle organik, bize ait bir şey vardı. Şimdi onu kaybediyoruz gibi. Zihin hiçbir zaman öyle değildi belki de. O yüzden yani tüm olumsuzluk risklerine rağmen ben bu konularda daha kucaklayıcı olan takipçilerdenim. Bu konuda takipçiyim sadece.
Peki. Çok teşekkür ediyoruz sizlere.